Good evening. I welcome you all on this scientific feed. And without further delay, we will start the first session. We have the great faculty for the first session, and we have three moderators who will be taking you forward. So I welcome Dr. Peter Kala from Czechoslovakia. I welcome
Hello.
Dr. Hello. I welcome Dr. Pradeep Gupta.
Hi.
Hi. And I welcome Dr. Cyril Noel, Dr. Hussein Hashmat, if he's already here. Hi. And Dr. Georgie Koshi. So thank you, moderators, chairpersons, our speakers. I will hand it over the proceedings to the moderators to start the first session. Thank you so much. Dr. Kala, you can introduce the first speaker,
Okay.
Dr. Cyril.
Okay. So thank you very much for inviting us and for being able to share with you the session here. So it's a great pleasure for me to give the first talk to Dr. Noel, and he will talk about rapid evaluation of chest pain and role of cardiac markers in emergency room assessment. And so please, the stage is yours.
So, hello everybody. My name is Dr. Cyril Noel. I'm an emergency medicine consultant. I'm the head of emergency services for Medcare hospitals in Sharjah and in Dubai. First of all, I wanted to say a big thank you to Shakeheart and to Dr. Mittal for giving me the opportunity to give this talk today. So this presentation is going to be about the evaluation of chest pain in the emergency department, with a major focus, because we don't have a lot of time, on how to rule out acute coronary syndromes in the patients who present to emergency departments. I'm going to start with a little bit of epidemiology, so we understand how big the problem can be. These data are from the USA, and it's estimated that every year there are 8 million people who present or taken by ambulance to an emergency department complaining of chest pain. As you can see, the vast majority get admitted. We think that it's between 50 and 70%, and a smaller part of this large number of people get sent back home. Of all the people who present, 10% will eventually be diagnosed with ACS. But what is quite worrying is that we know from evidence that of all the people who have an MI, only 70% of them get diagnosed properly. 30% will be missed, completely misdiagnosed, or they either don't complain of any symptoms, or they choose to ignore the symptoms and wait until it passes. I'm sure you've seen in your practice patients who come to the consultation with clear ECG or echo signs of an MI, and when you ask them when they suffered the heart attack, they look at you saying, but I've never been told I had any problems in the heart. So these guys represent 30% of all the cases of MI. And what is quite worrying, and what we have learned from data, is that between 5% of these MI cases actually come to an emergency department complaining of chest pain or anything else. They get evaluated, they get diagnosed with something else than an MI, and they get sent home. So it's based on those data that a lot of emergency doctors and emergency departments have started sort of developing some safeguarding sort of guidelines to make sure that we minimize the number of patients who get sent home with a reassuring diagnosis, who nonetheless are infarcting. So if you put yourself in the shoes of an emergency doctor, One of the first things that you learn when you go to emergency medicine school is to rule out the life-threatening causes of chest pain. There is a list of 6 of them. You know them all. ACS being the most frequent, followed by aortic dissection, PE, tension pneumo, tamponade, and mediastinitis. What we're going to do, like I said today, is just to focus on ACS because it's the most frequent of the most common sort of cause of presentation. And what we teach our juniors in emergency medicine is how to follow a systematic approach to be able to reach that stage where you say to someone, you can go home safely, you don't have an MI. So we follow, obviously, the 3-step approach of history finding, clinical examination, and testing. I'm going to start with the problems that we face at the history finding sort of stage. We classically describe the cardiac sounding chest pain and the atypical chest pain. And we've been relying on that for a very long time. There is now evidence, unfortunately, that in 22% of the confirmed cases of MI, the chest pain that is described is completely atypical, making that element of the history finding very, very difficult to rely upon. For instance, we usually describe the pain as being central radiating to the left. I have heard so many times in my career, someone presenting a case and saying, they've got chest pain, but it's going to the right side, so it's not cardiac. Quite the opposite. We now know that a central chest pain going to the right arm is twice more likely to be related to ACS than the same pain going to the left. The likelihood ratio are respectively 4.7 compared to 2.3. So again, we need to take those elements of classical sort of presentation very, very cautiously. Another example is when we qualify a chest pain of being musculoskeletal, can you reproduce the pain by pressing the area? Most of the time, we used to say to patients or juniors, oh, this is musculoskeletal, there's nothing wrong with the patient, can go home. Fortunately, we found that in 15% of confirmed MIS cases, there is an associated musculoskeletal type of pain with it. So I believe that the conclusion of this first stage is that we need to be very, very cautious. There is nothing in the history taking that is specific enough and, more importantly, sensitive enough to be able to reassure our patients or our junior colleagues and say, send the patient away, or it's not cardiac, you can just move on and progress in your diagnosis. That's the first key thing. Moving on to the clinical examination, as you very well know, there is nothing specific in ACS or MIs of clinical findings. Most of the time, the patients could look very distressed and very unwell, but there's nothing specific that you will be looking for in the clinical examination. So we're moving on to the testing stage. The minimum that we advise to do for any visit in the ED with chest pain is to start with an ECG, a chest X-ray, and some lab tests. Not enough time today to dwell too long on ECG and chest X-rays. It's a completely different subject, but I'm going to develop a little bit on the lab tests that we can offer. This is the classical dynamics curve that we all know, showing the different sort of specific heart markers. So the troponins on top, you've got CKMB, lactate, and the myoglobin on the left, right? We all know that very well. I think the most important sort of lesson to learn from that is that at the bottom left corner, we can see there is a gap. There is a gap between the time of the heart insult and the time the markers start to rise up. This is what is causing most diagnostic problems in the emergency departments, because we never know if we are going to find ourselves within that window of negative markers, despite the fact that there was a genuine insult to the heart cells. A quick word on CKMB. unless you work in a department where there is no access to troponins, there's no reason to use it really. It does not add anything to the management beside the cost. There's nothing specific. The timing is quite similar, and there's no added information. Most of the emergency departments nowadays have moved on and use TROP-T or TROP-I, depending on your lab contracts. Obviously, TROP-I is slightly preferable because it's less sensitive to renal failure. But anyway, the sensitivities now have increased quite dramatically, and they're very widely used instead of all the previous historical markers. So we know what to do with a positive result. I don't think it's too difficult. We call our colleagues and get some help from the cardiology team. But the question is what to do when we get a negative test. And that's when the risk assessment tools got developed. The first one that you probably know is the TIMI score, which is a risk assessment tool that gives you establish the risk of major event at 2 to 4 weeks after the ACS. It was initially developed for patients who had a confirmed episode, but it's been widely sort of open to the larger population. A few things that need to be said about TIMI. The first one is that the most important element is the troponin, the one with the little star at the bottom. And the second thing that needs to be said is that even if you score very low, 0 to 1, you still have a risk of MI, a risk of sudden death, and a risk of being taken to cath lab at 2 weeks, which is 5%. Most emergency departments believe, quite rightly, that it's not acceptable and the risk is too high. So we've moved on to using the HEART score. HEART because each letter stands for history, ECG, age, risk factors, and TROP. One of the beauty of this test is that it's more sensitive, but one of the problems is the fact that it only looks at one point. And like I said earlier, having one negative result is not enough, because you could potentially find yourself in that little window at the bottom left corner of the curve where the biomarkers haven't been released yet. So followed another project. It's a massive research. 23,000 people were analyzed in 15 different European hospitals, and it showed some very interesting results. That if you are low risk, if your first TROP is negative, and the second one measured between 45 and 120 minutes after the first one is not higher than 4 nanograms per liter, then your negative predictive value for MI is 92.5%. It means that the risk of having an MI for those patients who have 2 negative TROPs or a rise that is less than 4 is less than 0.2% at 1 month of the episode. So follow those research. A lot of places have started sort of implementing the heart care pathway, which is really putting together the conclusion of the heart score system and of the COMPASS study. And what it gives you is a tool to assess, to put your patients in 3 categories: low risk, up to 3 on the heart score, intermediate, up to 6, and high risk. Those 2 higher risk patients should definitely be discussed with our cardiology colleagues. But for the low risk patient, once you've done your scoring, it is perfectly safe to then add 2 TROP measurements. And if they are negative, those patients can be reassured. From an ACS point of view, it doesn't say that they haven't got any other problems, but from an ACS point of view, their risk of major event is less than 0.2, 0.4 at 30 days. So that's really the conclusion of what I want to update you upon, the fact that we have to be very, very cautious about the historical findings because they can be deceptive, and they are definitely not sensitive, nor specific, but not sensitive enough to be able to make a major clinical decision upon those elements of the history findings. The second key point is that we always need to do 2 drops in a row, preferably 3 hours interval between the first and the second measurement to see if there is any dynamic changes. And the last point is that it's now very much recommended to develop locally in your hospital, in your department, a pathway that integrates one risk assessment tool and those 2 sort of testing which need to be done at short interval. I hope you found this informative. I'm very happy to take any questions if you have any. And that was me. Thank you very much.
Thank you very much, Dr. Nail. It was a nice, very nice presentation and overview. And if Dr. Gupta, my co-chair, would like to ask you some questions, so please do it now. Please unmute. You are muted, Dr. Gupta.
I think we can take questions after the 3 lectures all together.
Okay, perfect. So, Doctor, I would like to ask you, Dr. Nail, to stay with us, and so we will have a couple of minutes at the end of the session.
Right. This is my pleasure and honor to introduce Professor Peter Kala and his contribution to the STEMI care. We are all familiar. And I met him, I think, in a Scale 1 or a Scale 2 conference in Dubai. He is a frequent visitor to Dubai. So his contribution is immense in STEMI care, and he is going to talk on STEMI care development, achievements, advancements, and challenges. Welcome, Professor Peter Kala. Please.
Hello, greetings from Brno, from the Czech Republic. I am very delighted to have the opportunity to share with you some thoughts about the primary PCI network, and I would like to thank the organizers for the kind invitation. Of course, I would be much more happier to be with you, but unfortunately, we have to go virtual. I don't have any relevant conflict of interest regarding this presentation. And I would like to be focused especially on the Stand for Life initiative, because I was leading this initiative for 4 years. And I'm sure that this initiative is a good example of the primary PCI network and what can be done during a relatively very short time period. So the aim of the Stand for Life initiative was to improve the delivery and patient access to the life-saving indications of PCI, and thereby reduce the mortality and morbidity, both of them, of patients suffering from acute coronary syndromes in general. But we were focused especially on patients with acute myocardial infarction with ST elevations. The initiative was supported by the EAPCI and the EuroPCR, and so this was a really very important initiative worldwide. These are still the objectives. We wanted to refine the regions and countries with an unmet medical need in the optimal treatment of acute coronary syndrome patients. And number 2, implement an action program to increase patient access to primary PCI, where indicated, of course. So the target, the goal, is to increase the use of primary PCI as number 1 of reperfusion strategy to more than 70% among all ST segment elevation patients. And of course, we would like to offer 24/7 service for primary PCI at selected invasive facilities to cover the country STEMI population need. At the beginning of this initiative, there was another target that was 600 primary PCI per million. But after recognizing the geographic differences, so this was not the goal anymore after that. The phase one was the situation mapping and data collection. And so it was published in European Heart Journal. And I will be back on this topic. Phase two was the learning the experience from the best practice countries. And it was also published in Euro Intervention. And in Euro Intervention was also published the phase three implementation in countries. And also after that, it was in European Heart Journal. So this is a very famous graph from the publication of Peter Williamski, who started this initiative. And we have a list of countries. You can see it here, and on the X-ray. And we can see the columns with three colors. So that means the green color, the primary PCI. The red color is definitely not bad. It's the thrombolytic therapy or fibrinolysis. But what was worst is the black part of the columns. That means that the patient suffered STEMI, but was not reperfused in any way. And it was very important because in countries with primary PCI dominancy, so you can see that the rate of non-reperfused patients was relatively low, about 20%. But on the contrary, in countries with thrombolytic dominance, it was nearly half of the patients that did not receive any reperfusion treatment. The Stand for Life started as an innovative business model. And it was the really platform, interactive platform for key healthcare stakeholders to work together in order to increase the patient success to innovation. And we had the Stand for Life Central and Stand for Life Local. And this collaboration was really crucial because it showed us that by using this model, it was really possible to be very effective and relatively very fast. So we had the steering committee and country champions, we had the task force, and we had the national project manager. And I think that this is one of the most important points from the whole program, because without that, and we had countries without national project manager, and the process was very slow going. So we tried to build an effective primary PCI network, followed by the public education. After that, there was the Stand for Life mission updated in 2015. And of course, the primary goal was the same, but after that, we tried to implement the ESC clinical practice guidelines on myocardial revascularization at national and regional levels. So it was Stand for Life basic level, the objectives, and after that, advanced programs. These programs were focused especially on patient education and health economy studies. So 3 results in implementing Stand for Life in Europe. What is possible to do? Within 3 years, it was possible to significantly decrease the rate of non-reperfused patients. So that means the black part of the columns. Of course, the target, you remember, that we would like to achieve at least 70% of all patients to be treated with primary PCI, the best available therapy. So the green part of the columns. But for the patients, for themselves, it's really important to decrease the non-reperfused rate. And it was possible to achieve in some pilot regions, like in Turkey. But on the national levels, well, there was also pilot regions in France. But on the national level, you can see that in Bulgaria, Greece, Serbia, Spain, so all these pilot countries that we started with, it was possible to achieve a lot. And without collaboration, without very good collaboration, of course, it wouldn't be possible. And you can see even expanded result. We the previous slide finished here, but we have Bosnia-Herzegovina, we have Portugal, we have Ukraine, and of course the baseline for them by using the primary PCI or reperfusion strategy in general was very different. But at the same time, the rate of non-reperfused patients decreased significantly within 3 or 4 years. So that was well, you can see the changes in colors during the time. This was published in 2010 in the European Heart Journal, but it was not, these data were not from 2010. It was a description of 2006, 7, 8 experience from the countries. And of course, the best would be to achieve the dark blue color, like in this part of Europe and some northern countries. And you can see on the right side that the dark blue color expanded and the light blue remained only in selected countries like Ukraine and some other regions in France and etc. Act Now, Save a Life, because Stand for Life was the whole initiative. But after that, we started the campaign, the patient campaign, education campaign, Act Now, Save a Life, and we wanted to increase awareness of heart attack symptoms and the urgency of treatment among Europeans. Not only Europeans, I have to say. So these were the universal visual icons deliver campaign messages. So the patient definitely has to know the signs, and their relatives as well. They have to act quickly. Under the optimal circumstances, they should call the emergency medical service, because still, of course, we deal with patients who don't call the EMS, but they go by car to the hospital, they go by their relatives, etc. But this is the optimal way, of course, because we have to diminish the rate of fibrillation, ventricular fibrillation, and other complications of the myocardial infarction. And of course, they have to receive the treatment that should be given just after the diagnosis has been set. One example about the quality control, and these data are coming from Portugal. And you can see the symptom, first medical contact, primary PCI, and door to balloon time. And this is the moment 0, so 2011. And you can see that the whole, we can say, ischemic time was relatively quite long. We can divide it into patient delay and after that system delay. Of course, the most important would be still patient delay, and we wanted to be focused on this part of the time interval and of the delay in general, because we want, of course, to shorten the total ischemic time. So the next target you can see here. So the whole Central Life Initiative, and we used this graph from the publication of from the guidelines. And so Act Now, Save a Life focused on patient delay. After that, Contract for Life, primary PCI, health technology assessment, and support this. If we build the primary PCI network, of course, we don't use it only for STEMI or acute myocardial infarction patients, but we can use it also for NSTEMI, especially high risk NSTEMI, and also for the stroke programs. It's quite important and quite interesting that in some countries they didn't have, at that time, they didn't have developed emergency medical service on the national levels. But during 2 or 3 years, if they were really collaborating with every activity within the states, so it was possible to build very effective system like in Romania. And this is the Stand for Life economic model. And you can see from Stand for Life model, various time periods. You can see Romania in 2009, 2014, and you can see the numbers of primary PCI. And this is the STEMI primary PCI per million population by countries. So this was very effective treatment. And at the same time, there was the first analysis, the health economic analysis, and showed us that it's a really money saving procedure because we decrease mortality rate, we increase morbidity as well, but it has an extensive impact on also on the social system of the countries. These are the Stand for Life pilot countries, outcomes and results. So you can see the burden of illness reduction, the lives that have been saved, and the net cost reduction. And you can see here that is really very, very effective. So one of the most effective treatments nowadays in medicine in general. So it demonstrates financial, economic, and clinical benefit of timely STEMI admissions and primary PCI. And it's quite significant reductions in morbidity, reduction in mortality, labor productivity loss, and of course, in general, disease burden. So all positive aspects have been showed and have been proved. So when I finished my my leadership of this initiative, so 21 countries from 5 continents were actively participating in Stand for Life initiative. So the Stand for Life member countries and affiliate organizations, because it was very important to collaborate with cardiology societies. It was Argentina, Saudi Heart, SOSIME, South African, and STEMI India. What are the Stand for Life logistics principles? So the pre-hospital management of STEMI patients that should be based on regional networks. And of course, we don't have any optimal network for any country, any region, because of geographies, because of the network of cath labs, etc. So we should design definitely the regional network to achieve the reperfusion therapy timely and effectively, and to offer primary PCI to as many patients as possible. At that time, it was recommendation 1B, but nowadays it's 1A, the strongest recommendation that we can have. The primary PCI capable centers deliver 24/7 service, and at latest within 60 minutes of hospital arrival. But of course, we now have even shorter targets in high volume centers, because we are able to reperfuse the infarct-related artery within 20 minutes on average. And written update STEMI management protocol. So that's quite important, and it should be done. So implementation, key learning points, engage all stakeholders. All stakeholders. That means not only physicians and the medical teams, but also politicians, payers, and patients organizations. Definitely, it was necessary to integrate the Stand for Life initiative into a government-supported program. Establish national ACS and AMI registry, and in Saudi, you have a very good registry and with quite a lot of publications that are very appreciated. And to build regional network and infrastructure. In some countries, as I mentioned before, they didn't have the effective EMS on national level, but it's possible to develop and increase disease awareness, educational campaign. So these are the take-home messages. Stand for Life initiative implementation can result in a significant increase in the number of timely PCI procedures for those with STEMI. The cost savings could be achieved from the improved productivity of the workforce, because PCI results in healthier, population compared to alternative treatments. And we know it very well, class 1A indication. And this cost savings more than offset the additional cost of PCI, staffing interventional cardiologists and building new cath lab. So this is maybe one of the most important points, working together, saving lives. So this initiative was ongoing, but in some other format and with a new name. So as a new initiative that is called Stand Safe Alive. And this has been ongoing, and I wish my followers great success, and all of you a lot of successfully healed patients. And of course, to you not to be completely exhausted by the time. It's a very exciting topic, and I'm very glad again for the invitation. Thank you very much for your attention.
Thanks, Professor Peter Kala, for excellent description and taking this initiative, which has transformed the STEMI care, not only all across the Europe, but across the world, because it has given a concept how we can increase the primary PCI intake and how we can reduce thrombolytic therapy, as well as those patients who did not get any reperfusion. So in the current era, ideally there should not be any patient who did not get any reperfusion. So thanks a lot for this initiative, and I hope throughout the world it would be adopted in letter and spirit, and we would be able to save more hearts and more patients, and we will be able to decrease morbidity and mortality. Thanks, Professor Peter Kala, again for your excellent presentation. Thank you again.
Hi everyone. Glad to see you at the beginning of the weekend in this session on STEMI. Thanks for Dr. Mittal for inviting me to this great virtual conference. And I'm honored to introduce the next speaker, Dr. Georgi Koushi. He's a consultant interventional cardiologist in Burjeel Hospital in Abu Dhabi, and he'll be tackling another aspect of STEMI care, this time not speaking of the networks and of the timings, but about the antithrombotics in acute coronary syndrome, which agent and which duration. I think it will be a wonderful lecture. So please, Dr. Georgi.
The art of antithrombotics in ACS, immediate, early, and delayed. Let's start by quickly revising the definitions and terminologies used in ACS. ACS involves a complete spectrum of unstable angina to NSTEMI to STEMI. Differentiating STEMI and NSTEMI is very easy with a clear ECG variance. Unstable angina, as defined earlier, was clinical and ECG findings in the absence of elevated biomarkers. But with the routine use of more highly sensitive troponin tests, the spectrum of unstable angina has almost always been redefined as NSTEMI these days. Starting with STEMI, anticoagulant therapy. Three classes of anticoagulants are clinically used in ACS. Heparins, which include unfractionated heparin, and the low molecular weight heparins. 2, the direct thrombin inhibitors, and 3, the synthetic heparin pentasaccharide fondaparinux. Unfractionated heparin has limitations in an acute MI situation. The heparin antithrombin complex cannot bind or inactivate thrombin which is within a clot. This clot-bound thrombin is a thrombogenic stimulus at a site of coronary thrombosis, especially in situations where the clot disruption happens by fibrinolytic agents. HIT is another risk with unfractionated heparin, which is much lower with low molecular weight heparin and fondaparinux. Low molecular weight heparin, however, has a lesser effect on thrombin and does not prolong the APTT in a predictable fashion, hence difficult to monitor. Low molecular weight heparin has a more predictable anticoagulant effect, however, and a reduced likelihood of inducing immune-mediated thrombocytopenia. Fibrinolytic therapy in STEMI. Heparin or enoxaparin is routinely used. The common practice, however, is to use heparin due to the ability to monitor its therapeutic effect. Theoretically, however, enoxaparin has enhanced advantages. The primary MACE endpoints occur significantly less with patients receiving enoxaparin, with most of the benefit attributable to a reduction of MI when compared to regular heparin. Fondaparin X is a reasonable alternative when the risk of bleeding is higher in patients and in those who are not planned for a PCI. However, in patients who have been treated with fibrinolytic, fondaparin X is not recommended. In this setting, bivalirudin has a higher bleeding risk as compared with heparin. Anticoagulation for at least 48 hours and up to 8 days is the standard practice. In the background of primary PCI, all patients planned should receive anticoagulant therapy as it significantly reduces the risk of acute thrombosis. Heparin is the common preference as compared to other anticoagulants, especially in patients receiving ticagrelor or prasugrel. Bivalirudin may be used as an alternative in patients who receive clopidogrel and also at patients with increased bleeding risk, including women, individuals with renal dysfunction, use of a femoral artery approach. The ACC guidelines for STEMI patients undergoing primary PCI, the following supportive anticoagulant regimen are recommended. Unfractionated heparin with additional bolus doses administered as needed to maintain therapeutic ACT levels. Bivalirudin with or without prior treatment with heparin. Class 2A, patients with STEMI undergoing PCI at a high bleeding risk, it's reasonable to use bivalirudin monotherapy in preference to a combination of heparin and a GP2B3A inhibitor. Class 3 harm, fondaparin X should not be used as a sole anticoagulant to support primary PCI because of the risk of catheter thrombosis. Acute NSTEMI antiplatelet therapy. Broadly, in patients with NSTEMI, aspirin should be given as loading dose as quickly as possible at 162 to 325 milligrams of uncoated aspirin, which should be chewed or crushed to establish a high blood level quickly. There is no evidence that a higher dose is more effective and they may lead to actual greater gastric irritation. Aspirin 75 to 100 mg is continued indefinitely. Alongside with aspirin, a P2Y12 inhibitor should be initiated, and this is called dual antiplatelet therapy or DAPT. The choice of the P2Y12 inhibitor and the timing of its administration depends on the choice between an invasive and ischemia-guided management strategy. For NSTEMI patients assigned to an invasive strategy, the timing of the diagnostic angiography guides the use of the P2Y12 inhibitor. If it's anticipated to occur within 3 hours, ticagrelor 180 mg as soon as the diagnosis is made, or prasugrel 60 mg after diagnostic angiography is given. If there's a delay in the diagnostic angiography, ticagrelor 180 mg as soon as the diagnosis is made is given. If it's ischemia-guided conservative strategy, ticagrelor 180 mg as a part of DAPT is recommended. Use of intravenous glycoprotein 2B3A inhibitors is not routinely indicated as an antiplatelet with the exception of certain situations. 1. Ongoing ischemia despite the DAPT and plan for an invasive approach. 2. Angiography suggests a higher risk such as a large thrombus burden or an intraprocedural thrombotic complication, particularly if they have not received prasugrel or ticagrelor. GP2B3A inhibitors, when used in NSTEMI, they are not started until after diagnostic coronary angiography in most cases. Based on the ACUITY timing and early ACS trials, there was no benefit found from early initiation and an increased risk of bleeding was present with pre-angiography use of the same. Now, there are challenges which we face with aspirin use, primarily GI intolerance, which includes bleeding and more commonly dyspepsia and nausea, which can be treated with a proton pump inhibitor or lowering the dose of aspirin to 7,500 milligrams per day. Entry-coated aspirin may be of some benefit, but it does not protect against GI bleeding. Another challenge is aspirin allergy. For this, aspirin desensitization is an option when the invasive approach can be delayed in stable patients. If desensitization is not a possible alternative, depending on time of the invasive procedure, Ticagrelor or pasural monotherapy over clopidogrel is preferred. Cilostazol may be a reasonable alternative. The rationale for the use of early oral DAPT is that platelet adhesion and aggregation are early steps in the formation of occlusive coronary artery thrombus. DAPT is directed at limiting these early steps, which may result in thrombus occlusion of a coronary artery or stent thrombosis in patients who are stented. The benefits of DAPT was clearly established in the CURE trial. At an average follow-up of 9 months, the combination therapy led to significant reduction in all combined primary endpoints of death, non-fatal MI, or stroke. Some brief highlights in the P2Y12 therapy. Ticagrelor or pasugrel are preferred over clopidogrel for most patients with NSTEMI. The issues of cost or availability may influence the choice of this inhibitor. Clopidogrel is often preferred in older aged patients. Ticagrelor should be avoided in patients at a risk of symptomatic bradycardia, including those with second or third degree AV block on the ECG. Also, it should be avoided while using strong CYP3A4 inhibitors like ketoconazole, clarithromycin, ritonavir, etc. This is because the increased risk of ticagrelor exposure and increased bleeding risk. Pasugrel should not be given prior to coronary angiography, and it is contraindicated in patients with a prior TIA or stroke. Clopidogrel is preferred for patients of higher bleeding risk like hemorrhagic stroke, bleeding diathesis, etc. Cangrelor was US FDA approved in 2015, and it has a very rapid onset of action and can be given in patients who have not been prior treated with a P2Y12 platelet inhibitor. However, it is not routinely used. Coming to dosing, pasugrel, a loading dose of 60 mg and maintenance of 10 mg per day, which can be reduced to 5 mg per day to reduce DAPT intensity and decrease bleeding risk, especially in Asian races and also in patients 75 years or older who weigh less than 60 kilos. Ticagrelor, loading dose of 180 milligrams and a maintenance dose of 90 milligrams twice daily. For those patients who will be continued on ticagrelor after 12 months from the diagnosis, reducing the dose to 60 mg twice daily is an option. Clopidogrel, loading dose of 600 mg and a maintenance dose of 75 mg. So how long can we give DAPT? If a patient has tolerated DAPT for 12 months, it can be continued for as long as an additional 36 months, as evidenced in the DAPT and the Pegasus trials. The DAPT trial compared 18 months of DAPT in stented patients who had already received DAPT for 12 months without any major complication and reduced MACE. The Pegasus trial assigned patients to 2 doses of ticagrelor, 90 and 60 mg, or a placebo, and all patients continued aspirin. A composite of MACE was found to have occurred less with the ticagrelor arm, and the safety endpoint of a TIMI major bleeding, though it was higher in the ticagrelor arms, there was no difference in the rates of fatal and non-fatal intracranial hemorrhage. At times, it may be required to switch between potent P2Y12 agents and clopidogrel for reasons such as increased bleeding risk or even cost. The ideal strategy would be in patients who receive TICA, give the first dose of clopidogrel 12 hours after the last dose of TICA with a 600 mg loading dose. And for patients on pasugrel for less than 5 days, a loading dose of 300 mg of clopidogrel may be given 24 hours after the last dose of pasugrel. And if pasugrel has been given for more than 5 days, start clopidogrel 75 mg 24 hours after the last dose of pasugrel. When switching to TICA, we have to load with 180 mg at any time within 24 hours after the last dose of the previous antiplatelet, followed by a 90 mg twice a day. One of the biggest challenges we face is the concomitant use of antiplatelets with the requirement for anticoagulation in patients with atrial fibrillation, prosthetic heart valves, etc. So in this case, the patients can be categorized into multiple risk groups. The lowest spectrum being a low thrombotic and a low bleeding risk, where the triple anticoagulation with a plan to stop aspirin early would be the strategy, as compared to a high thrombotic and high bleeding risk group where triple anticoagulation and continue aspirin if possible for as long as you can, for 1 month perhaps, and continue clopidogrel for 6 to 12 months would be the strategy. For patients who have completed 12 months of antithrombotic use, we can move to a DOAC monotherapy for low thrombotic and high bleeding risk spectrum, and DOAC with a single antiplatelet for high thrombotic and low bleeding risk spectrum. Thank you.
Thank you very much. It was a great talk and great topic, of course, because it's combination, and I would like to open the discussion. So please, we have 3 speakers here. So the first, Dr. Noel, about the emergency room and the rule in, rule out, the strategy. After that, it was the primary PCI network and antithrombotics. So please, Dr. Gupta, Dr. Heshmat, please.
Yeah, so let's initiate with what's your opinion, Dr. Noel, about 1 hour second troponin and rule in or rule out MI?
Thank you very much, Dr. Gupta. There's not a lot of data to compare the best possible time between the 2 drops. But most places recommend between 2 and 3 hours, just to make sure that if the event has been significant enough, you give enough time for the proteins to be released. But at the moment, there's no comparative data. The COMPASS study integrated different sort of times between 45 minutes and 120 minutes. So that's quite a significant difference between the centers. But I personally think that 3 hours is safe.
You think extending till 3 hours, the sensitivity and positivity will increase, isn't it?
That's the impression that most of us have in emergency medicine. Yeah. Obviously,
Right.
you need to have the place and the time to do that in a very busy department. It's not necessarily easy to put a patient on a stretcher for 3 hours and wait for the results. But ideally, 3 hours is safer in terms of sensitivity. Yeah.
Okay.
May I ask you, because
So
what do you think? What do you think about the strategy that bedside troponin could be done in the emergency, because EMS, because that's of course possibility to shorten the time in the emergency room.
Yeah, it would be perfect. The problem is that the sensitivity of those measurements are not exactly identical to the standard ones that you send to the lab. There's again a lot of data that has not really been analyzed, but it's difficult to compare 2 different sort of measurements. And ideally, if you compare a point of care testing with another point of care, I think it's completely valid. But comparing a point of care with a standardized lab one is probably a little bit risky.
Yeah.
But ideally, yes, I would love to have access to those testings if they are validated and reproducible. Anything else? Yep.
The question, now we are seeing a tendency in the non-ST ACS situations to avoid preloading. And what do you think of the applicability of this to the STEMI environment?
I'm not sure if I've got who you were asking this question to.
I'm asking, it can go to the emergency, and it can go to Dr. Peter Kalla
Koshi.
for this, and for Dr. Koshi as well. Yeah.
Right.
I think I'm going to let my cardiologist colleague answer that one.
Okay.
Yeah, I think that's. Dr. Koshi, are you around?
So, Dr. Heshmat,
Would you like to comment?
Dr. Heshmat, could you repeat the question, because it was difficult to hear?
Okay. What should we recommend about the pre-treatment with antiplatelets? Should we do it routine? Should we do it in the ambulance, or should we do it in the emergency? Should we do it in the cath lab? What's the best practice in this regard?
Well, if we would deal with the STEMI, clear STEMI, so I'm sure that as soon as possible we can deliver the medical treatment, the effective medical treatment. So it's better for the patient, and also it's the safest way to be really sure that there is some effectivity in the cath lab already during or before primary PCI, because we know currently we know very well that clopidogrel, it takes at least 4 hours to have an effect. But if we deal with ticagrelor or prasugrel, so after 1 hour we already have some effectivity and nearly full effect after 2 hours. And so during the transplantation, it's possible to get the full antiplatelet effectivity. On the contrary, if we deal with NSTEMI population, so I think that it's quite different population, and so quite often we have to send the patient with multivascular disease to surgery, etc. So I think that if it is very high risk NSTEMI, so we should go in the same way like the STEMI. But if it is moderate or low risk, even low risk, so I would definitely wait.
Thank you.
So, all right, there are no questions from the audience.
Yeah, Dr. Mittal, thank you.
Yes.
Dr. Mittal. Yeah.
So thank you so much. All the speakers have done a wonderful job. Dr. Kala, you were the chair of the Stand for Life, and now there is a new entity in a different way, but working on the same direction. How do you see this movement going forward in the eastern part of the world, like Asian countries? What is the progress in like 5 years, or we are still stuck at the same stage?
Of course, in other regions, especially in Asia, Asian regions, so very populated regions, it's difficult to have a really full primary PCI network and to cover the whole population. It's impossible. But I think that much more beneficial on the nationwide level would be to use the pharmaco-invasive approach. And of course, to start with fibrinolysis, and we have very good agents now. And after that, in general, it's recommended to transport all patients to the cath lab. But I think that we can already select the high-risk patients at least.
Yeah. So there is progress. I mean, is there any data to suggest that there is really change in this paradox? What you said, the paradox: not treated, then treated with thrombolysis versus treated with primary PCI.
Yeah, so it's there is a definite progress, and but it's on the regional level. It's not on the national levels, but on the regional levels. But some regions are doing perfect.
Yeah. Dr. Koshi, there was a question for you, which Dr. Kala answered, but it will be good if you also give your comments that preloading should be done for non-STEMI or STEMI at what stage? That was the question from Dr. Hussain.
So if it's, in my opinion, documented STEMI as far as our non-STEMI, preloading should be done at diagnosis, in my opinion. And there's sufficient data to suggest that the earlier the platelet inactivation starts, the more beneficial it is. And a lot of us as operators, we know that despite the preload on case-by-case scenario in the cath lab.
Okay.
What was the general consensus on that, Dr. Mittal?
Yeah. Okay. Thank you.
Maybe one more question on Dr. Noel.
Yes.
I would like to ask you about what is maybe the most important problem for you in the emergency room with positivity of troponin, because we call it somehow troponinism, and so how do you deal with that? And maybe we have some troubles with the connection.
Yeah, it's breaking.
Yeah. So, question for Dr. Noel.
Yep.
How do you
Okay.
deal with the positive troponin? Dr. Kala asked you this question.
Yeah, because we have quite a lot of patients and we so-called troponinism. So a lot of diagnoses that are associated with positivity of troponin. So how to deal with them?
Could you rephrase the question, because I'm not sure if I understand properly.
Okay. So quite a lot of diagnoses have positivity of troponin, and
Right.
yeah, that's the question.
Okay, so how to avoid the false positive, you mean?
Yes. Yes.
Well, it's the specificity is, again, from my perspective, I tend to prefer trop I to trop T because it's less sensitive to the renal failure. It's usually a little bit more specific, but you always, with these molecules, you're always faced with a problem that is not actually specific to ACS, because any kind of injury, as you all very well know, to the heart will tend to release some even a stabbing to the heart will release some trop. So there's nothing really specific to the ischemic process. And I can't really, I think it's just about integrating everything into the general picture, the story, the risk factors, the comorbidities. That's in my experience the best way to try to find your way through the difficulties of the false negative and the false positive.
Okay.
Because the molecules are not specific. No, thank you very much.
Thank you very much. And I would like to ask Dr. Gupta, my co-chair, to conclude, because it's time to do that.
All right. As there are no questions from audience and we all had a very nice discussion among ourselves, I would like to thank all the speakers as well as all the moderators, and my heartfelt thanks to Dr. Brajesh Mittal for organizing this wonderful virtual fifth annual conference of Shake. So let's all give a big hands to Dr. Mittal for organizing this conference, and thanks to all.
Thank you.
All right.
Bye-bye.
With this, we close this session. Nice to hear and interact with all of you. Thanks a lot.
Thank you.
Thank you.
Bye-bye.
Thank you.
Thank you.
Good evening, colleagues, friends, and respected chairpersons. My talk is on a new and exciting therapy for lipid management. So the learning objectives are as follows. Cardiovascular diseases are number one killer. LDL is the key factor. Statins are the backbone of therapy. Ezetimibe and PCSK9 inhibitors are established non-statin therapies. And then there is a new kid on the block. Let's see what is that. So we very well know that cardiovascular disease are the number one killer. As many as 17.9 million people die each year from cardiovascular disease. More than 2 decades before, it was well established that there were clear benefits of lowering cholesterol in terms of total mortality as well as in coronary heart disease mortality. You continue to reduce the cholesterol and you continue to reduce the mortality, both total as well as CHD. The statin trials were the landmark trials, and there were a number of these trials done in both primary and secondary prevention settings. It was very amazing to see that whatever LDL you start from, and when you continue to reduce the LDL at whatever level, you continue to give benefit to the patients in terms of event rates. Obviously, it is far more a steeper curve in secondary prevention as compared to the primary prevention, but this is applicable for both the strategies. And this actually translated also into the stroke prevention. Each 1 millimole per liter of LDL reduction led to a significant 28% reduction in the event rate. And there was no evidence of any lower LDL cholesterol threshold. You continue to reduce LDL at whatever level, and you continue to reduce the cardiovascular events. Despite all this, there was approximately 50% patients were found not to be controlled. Either they were not treated well, they were not treated adequately. And though this slide dates back about 9 years before, but I'm sure that this number has not increased much. So because the statins alone, though they were the best therapies, but they alone were not sufficient because of intolerance, because of their optimum or maximum possible utility value. The alternative therapies were also came into force. So non-statin LDL lowering therapies, which are already known to us, one is ezetimibe based on IMPROVE trial, and the second is PCSK9 inhibitor, alirocumab and evolocumab, which are available here based on Odyssey and Fourier trials, and both are now in the guidelines. In order to reduce the LDL, the total control lies with the LDL receptors, and all medications in one way or the other act through the LDL receptors. So circulating LDL binds with the LDL receptor. The combination goes inside the cytoplasm, and then the LDL is cleared off from the bloodstream, and the receptors returns back. This is how the whole homeostasis works. So LDL receptors on the surface of the hepatocytes bind with and clear LDL particles from the bloodstream, and this is regulated. So you can see that LDL concentration is regulated by the level of LDL receptor expressions on the hepatocytes. So what are the ways to have effect on LDL receptors? So now it seems that LDL is controlled by LDL receptors. So what are the ways to affect or influence the LDL receptors so that there is more clearance of LDL could be possible? Statins increase the number of LDL receptors by upregulating them. PCSK9 inhibitors inhibit PCSK9, so thereby the LDL receptors are preserved in number. There is less restriction of LDL receptors. And this new therapy, which we are going to talk about, inclisiran, it prevents PCSK formation, and thereby there is availability of more LDL receptors. So this is how these three types of agents work differentially. So inclisiran was established and has been established and is still being studied in a large program, which is known as Orion program. So what is inclisiran, first of all? It is a small interfering double-stranded RNA. It acts in the hepatocyte at the level of the cytoplasm, not in the nucleus. And it's a bit complex here, but what I want to convey the message that inclisiran reduces the formation of PCSK9 protein. Thereby, there is less restriction of LDL receptors. This is how it works. So it is the first and only therapy that utilizes the small interfering double-stranded RNA mechanism, which lowers LDL cholesterol, and it increases the LDL cholesterol clearance from the circulation. And its effectiveness and LDL lowering effect is sustained over the course of the extended dosing intervals. There are three different phases of large trials which were conducted with this agent: phase 1, phase 2, and phase 3. Some of them are still ongoing trials. And the trials which actually proved the utility and established the dose, phase 3 trials 9, 10, 11. These trials actually provided the backbone for this agent to come in the market and being already approved. So what were the criteria? What were the patient groups in those trials? Orion 9 for heterozygous familial hyperlipidemia. These all trials were done in a similar way. on the maximally tolerated dose of statin and if targets are not met. So if patients with HeFH were more than 100 milligram per DL, if established atherosclerotic cardiovascular disease patients were having LDL more than 70 despite the statin therapy, and in Orion 11, if ASCVD risk equivalent patients, they were having more than 70 or more than 100. So if they are more than target, then this agent was utilized. Ezetimibe use was not compulsory. In one trial, which is Orion 7, it was also shown that no dose adjustment of inclisiran are necessary in patients with renal impairment. How the trial was conducted? The patient was given first injection on day 1. The second dose was given at day 90, 3 months later, and subsequent doses were given at 6 months apart. So only the second dose is given at 3 months. The further dosing were done at 6 months onward. So in this trial, in this group of trials, I would say 9, 10, 11, the total 4 injections were given and the study was done at the end of 510 days. In all these 3 trials, there was a significant reduction in LDL cholesterol percentage between 48 to 52. So average, you can say all the trials showed a 50% lowering, which was sustained by inclisiran over a period of 18 months. In terms of actual numeric reduction of LDL, again, it was in the range of 59 to 51%. The effect was maximum in Orion 9 with the heterozygous familial hyperlipidemic patients. And up to 74% of patients from Orion 10 and Orion 11 were able to achieve guideline recommended LDL cholesterol levels, which were less than 75 milligram per DL. So it was a hugely successful trial with very, very satisfactory and very, I would say, encouraging results. Interestingly, in the trial itself, the PCSK9 level was monitored in each of these trials. And in each trial, you can see that the PCSK9 was reduced by 60 to 70%. And this is how the main basis by which the inclisiran worked. The HDL cholesterol actually increased by 7 to 8%, up to 10%, in fact. That was another important finding which was seen in those trials. So what is the efficacy? 2 doses of the 300 milligram inclisiran, which is equal to 284 milligram of the actual substance regime at day 0 and day 90, showed the greatest efficacy over the dosing interval of 6 months. And it provided effective and sustained lowering of LDL cholesterol, and it was observed in all across the pre-specified subpopulations, including patients with diabetes, metabolic syndrome, and or impaired renal functions. Side effects were very well matched as compared to placebo. The only side effect which was more common was injection site reaction, obviously, in the inclisiran group, and they were predominantly mild. None were severe or persistent. Now we are going to have more trials, which are ongoing trials. There are extension trials because the first 3 trials which I mentioned, 9, 10, and 11, were performed with 4 doses in 510 days duration. The Orion 3 and Orion 8 aims to do the trials on a longer duration. And the very important trial which we would all look forward to is Orion 4, which will be a cardiovascular outcome trials involving 15,000 patients, and this will be very encouraging. There is a philosophy behind the development of such medications, and there is a way forward to look at things differently. As the therapies are improving, we can see a clear change in our perception, in our strategy, in our future anticipation. We start with the medication, for example, for lipid therapy by statins, which patient would need 365 pills a year. Then monoclonal antibodies, 26 injections, 2 per month. And then this inclisiran, 2 injections per year. And then there may be a development of a vaccine to prevent LDL formation, maybe 1 or 2, or in a lifetime, some boosters. Or in the end, we may end up by gene correction and gene editing, which could be required once in a lifetime. So we are talking in terms of increasing adherence by reducing the frequency of the medication or therapeutic regimens. So, ladies and gentlemen, Inclisiran provides effective and sustained LDL cholesterol lowering with 2 maintenance doses per month. This is how it is given. Day 1, first dose, 3 months, second dose, and then 2 doses every year subcutaneously. And it is found to be very safe, profile similar to placebo in the studies. The safety profile has been confirmed in more than 3,500 patients. The current status is as follows. EMEA, European Medicine Association, approved this agent in December 2020, and UAE got an approval in February 2021. It is now available. We have not yet used. So in the end, can we call it as a blockbuster? Only the time will tell. But at this point of time, yes, this is a very, very novel new medication to control the lipids. Thank you so much for your kind attention. Good evening. So I hope I could present a glimpse of the future therapy for lipid lowering. In a nutshell, it's an exciting new therapy which we are all looking forward. It's already been available. And we feel good that we are having more and more agents now in our armamentarium to deal with this specific entity, which is crucial for the prevention of cardiovascular diseases. We move on to the next part of the program, which is a 20 minutes inaugural session. And let's join hands together in taking some time out from the actual medical content to this inaugural speech. And dear delegates, cardiovascular diseases, especially heart attacks, are the #1 killer in the world. And amounting to approximately 17 million deaths a year. We had started an humble beginning in 2015 to impart knowledge and create awareness. The current version, Shake, Saving Heart Attacks Key Efforts, was launched in January 2020 under the patronage of Dr. Azad Mupen. The objectives are mainly educational, both for the healthcare professionals and for the community. In the past 1 year, a series of programs were conducted for the public, and now this particular program is specifically meant for the professionals in this field. Friends, it is my immense pleasure to present to you this academic venture, the 5th Symposium on Heart Attacks, Saving Deaths and Damages. This year, it is completely virtual on 3D platform. The 2-day long proceedings are divided in 9 sessions covering 31 lectures and comprising of 44 distinguished faculty members who are of national as well as international repute. Most topics are generic and suitable for a wide range of healthcare professionals. Any healthcare professional who is involved in providing cardiovascular prevention in their daily practice. Due accreditation process is underway with Dubai Health Authority. I'm sure this endeavor will contribute immensely to the needs and knowledge in this area. A team of colleagues have put in relentless efforts in last 4 weeks to make it a rewarding and successful journey. We have been supported by a number of other entities. There are hubs you can see in the online platform. You can visit the hubs. These are also the source of knowledge. They display the recent advances, the current medicines, and what's going on forward. With this introduction, I formally invite His Excellency Dr. Aman Puri to formally inaugurate this Shakeheart 2021. Thank you.
Namaskar and a very good afternoon to all of you. Dr. Brajesh Mittal, Chairman Shake, Dr. Azad Mupin, Founder, Chairman and Managing Director of Aster DM Healthcare and the patron of Shake, Dr. Naresh Trehan, Chairman and Managing Director and the Chief Cardiac Surgeon at Medanta, distinguished doctors, speakers, panelists, ladies and gentlemen. I'm really honored and privileged to join all of you and share a few thoughts at this very important conference. First of all, I'd like to congratulate the Shake core team for organizing the 5th annual Shakeheart on saving deaths and damages from heart attacks. The Shakeheart's motive to increase awareness among vulnerable populations of the importance of early recognition and early treatment of this major killer is definitely appreciable. On a broader level, as governments strive to meet their objective of ensuring affordable and quality healthcare for all their citizens, the Consulate General of India in Dubai hosted the UAE India Healthcare Conference end of last year to explore opportunities for collaboration between the two countries. The National Health Authority of India and the Dubai Health Authority are continuing to explore ways and means of formalizing their relationship and furthering their partnership. I would like to congratulate UAE for the Waterfalls Initiative, which India formally joined last year through the participation by Federation of Indian Chamber of Commerce and Industry and by the Apollo Group of Hospitals. Such initiatives of supporting continued medical education are very critical to support the advancement of medicine globally. Due to the COVID-19 pandemic, which is an unprecedented crisis, healthcare has been brought to the forefront. And what is important is that our realization that health systems across the globe need to communicate more effectively with each other. In this respect, I feel such conferences are very important to bring healthcare professionals in different parts of the globe together on one platform to discuss ways and means of advancement in specific fields of medicine. I would like to also take this opportunity to congratulate the Indian healthcare entrepreneurs based in UAE who have created admired and respected brands such as Aster and Medcare, VPS, Zulekha, Prime, and Thumbe. Also, UAE-based Indian healthcare entrepreneurs have invested into India and set up hospitals there, including Dr. Azad Mupin, who was one of the pioneers in this field. Today, we have several others like Zulekha, VPS, and Metra Hospital, which is working very effectively and contributing to healthcare delivery in India. I would also like to say that Indian doctors are playing a disproportionate role and making extraordinary contribution to health systems in several parts of the world, and especially in the English-speaking world. With these words, I would like to once again thank Dr. Mittal for this very kind invitation, and I wish Shakeheart 2021 all the success. Thank you so much. Namaskar.
Formally inaugurating the Shakeheart 2021. Among us, we also have the guest of honor as well as a faculty member, a very renowned doctor in India, and none other than Dr. Naresh Trehan, who has been a pioneer in establishing advanced cardiovascular care in India. I request Dr. Trehan to deliver his message as a honorable guest first, followed by his scientific lecture, which will be subsequently follow in the coming session. We are just waiting for him to join. Maybe he will be joining in a couple of seconds or minutes. Just bear with us. Our next session starts exactly in 10 minutes at 5:40. Dr. Trehan was actually online about 15-20 minutes before. Maybe he got stuck in something. We are just waiting. Yeah. Please bear with us for a couple of more minutes. He should be with us soon. Good evening, sir.
Good evening.
Good evening, sir. Welcome.
Thank you. Thank
We are
you.
happy to have you as honored guest of honor for this inaugural session. Just now, His Excellency Dr. Amanpuri spoke and delivered his message. And we request you, sir, to please say a few words before we go for the actual educational session.
So, the pleasure and honor is mine, and my good wishes and good evening to all the delegates and the organizers, especially you, Dr. Mittal, for organizing something like in this period, which we've been through a terrible 1 year, and we don't know when it's going to end. To be able to get a scientific exchange going like this is always a breath of fresh air. So thank you for inviting me. Now, we have to talk about anything that we do in life in medicine uh, in a perspective which is quite different today than it was last year this time. And that perspective is that when we talk about heart disease, acute myocardial infarction, we talk about the rapid progression of knowledge and technology in the treatment of cardiac diseases, especially in the event of acute myocardial infarction. We also talk about now the added COVID syndrome, the post-COVID syndrome, and all that addition that has happened in this past year, which we have learned, and a lot of it is still unclear, but a lot of data is already there, especially when we talk about it from Vedanta. We are talking about having collected data on large series of post-cardiac syndromes in our whole experience of, because we were one of the main centers for COVID treatment in the private space. So we've had a lot of accumulation, and I will speak about it later. But what I'm saying is that there is a new perspective to life, and I'm glad that today is one of the first few seminars where we have to talk about same thing that we were talking about for many years in a new perspective. So I went through your program, and you got some very exciting lectures, and I wish you all the best for this whole event to go well. And I'm sure many people who are online now will benefit from this discussion. And with that, let's move on, and good wishes to everybody. Thank you very much for inviting me and giving me the privilege of being a part of this important seminar.
Thank you very much, sir. Your presence itself speaks the volume for the importance of this program. And I'm sure the audience will be much more enlightened with the 2 days scientific activities. We can now move on to our next session. And for this session specifically, I have invited you, sir, as the keynote speaker. May I request Dr. Rajiv Lochan, if he is online, he's a very senior cardiologist, to be the chairperson of this session. Good evening, sir. Welcome to join as a moderator and chairperson in this session. And
thank you, Dr. Brajesh. You always makes a very interesting meeting, and it's very practical. The most important thing is day-to-day life. We use all the things, but you collect, and especially you have chosen a distinguished faculty. Welcome, Dr. Trihan. It has been our pleasure to have you with us in this meeting. We will learn from your experience. I don't think Dr. Naresh Trihan needs any introduction to this crowd, not to any crowd actually. He is one of the finest doctor trained in the first medical college of UP, which is the King George's Medical College. And many of them may not be aware that was the first college which provided the MBBS degree. And he was done excellent training in the US and came back and started excellent center in Delhi, technically the first center which really took off the cardiac surgery, and most of the people didn't have to go to the south. So welcome, Dr. Trihan, and just enlighten us with your knowledge and guide us in the management. Thank you, sir.
Well, thank you, Rajiv. It's good to see you again. I see you look the same for so many years. I'm seeing you after a few years. I mean, we are all minus some hair, that's about it, but the rest of you looks great. So, right, I think we are all in the same vintage. So now, getting down to the acute myocardial infarction and the transition from the old days to now. And you are, of course, the master of it, but I will attempt to share my knowledge, what I have. So, I mean, no matter what the presentation has been today, we are not helpless anymore. It used to be a decade, 2 decades ago, if somebody had a myocardial infarction, we had very few choices. But now that there has been a lot of technology coming to our aid, lot of knowledge, shared knowledge around the world, that has now brought us to a point where we know exactly what to do when somebody appears in our emergency room with an acute myocardial infarction. So from the ones that who are ST depression, what we call now non-STEMI, to real elevation, ST elevation infarcts, we know how fast we need to move. So the term that came is basically if you are in the periphery and there is no facility for intervention, then of course the clot busters, then transport as fast as possible to the nearest center that you're tied up with, and then we count from door to needle time. So these are all very, very sort of, they're not today's terms, but they are very current terms. And what we know now is that we show off that in our institution, the door to needle time is half an hour, 30, 25 minutes, 15 minutes, whatever we can accomplish, we feel very proud of that. So this is where we are at today, that if you know that somebody has an acute infarct in the middle of it or in that window, then take them straight to the cath lab and do whatever is necessary, whether it will revert back to medical therapy, whether it would be intervention by stenting to one or two vessels, or whether it will be emergency surgery. But that is the interesting part. In the last decade, all this has changed. If we used to do at least 3 to 5 emergency procedures a month, where we were actually trying to do rescue CABG. Today, if we do one every 6 months, that's a lot, because our colleagues in cardiology have become so accomplished in dealing with acute coronary syndrome or acute myocardial infarction that today we don't really have to worry about that somebody needs revascularization. Rarely does it happen that somebody has a bad left main which cannot be stented, then we need to put a balloon in and take them to the operating room. So this is all current. It's current knowledge to everybody. There's no sort of rocket science to it. But then let's break it up now from post myocardial infarction. So basically, we have now adopted around the world, and I'm sure everybody's up to date with the fact that we don't give up anymore. In the old days, we used to say somebody who has 15, 20, 25% myocardial infarction, oh, you need to go for a heart transplant. You don't hear that at all. In fact, especially at Medanta, at our institution, I mean, maybe 99% of the people who we used to say you need a myocardial a heart transplant, today we can fix them one way or the other. So whether we have, like I pride myself, if I've done anything in my life, is the fact that made it possible to now make every possible coronary artery disease patient, whether they are 15, 20, 25%, as long as they have hibernating myocardium, we can actually treat them with a revascularization strategy. It can be stenting, it can be CABG, it can be a hybrid procedure. So today we almost have a solution for almost everybody, non-LVAD, non-transplant. Okay, so then we actually have that rare case where we have a poor ventricle, and in addition to that, we have extremely poor vessels which cannot be revascularized by any means. And the only option we are believers. We are believers in enhanced external counterpulsation. We've done a very large series for the last almost 20 years. We have documented all the results of how 85% of the patients who do not have favorable coronary anatomy but have viable myocardium, that they can actually be treated successfully by relief of symptoms. And even you see that revascularization taking place, micro revascularization, in a large number of patients as documented by PET scans. So failing that, of course, then we have the LVAD, and then we have the heart transplant. As you know, with the advent of seat belts and helmets and stuff like that, you now see very few patients who are candidates for as donors, cadaveric donors for organs, very few. So especially in cities like ours, where we have a very educated population, and they actually practice all the safety and all that. So it happens, but not frequently enough. Then we go on to say, what happened to the whole population, whether it was pre-existing coronary artery disease by way of critical disease or non-critical disease or medical therapy, patients who have been stented, and patients who had only no disease before, but then developed again a syndrome secondary to COVID infections. So now what we know is that people who have myocardial infarction before, compromised ventricles, compromised circulation, when they get that cytokine storm inflammation in their myocardial fibers, that myofibrils do get first edema, inflammation, and then fibrosis as evidenced by our MRI studies. So it's prudent now to say, while you are looking at HRCT, you should also be looking at the echocardiographic evidence of myocardial involvement. Now, what has happened is that we know our standard treatment of favipiravir, whether we do remdesivir, or then we introduced, I mean, around the world it was introduced, but we did a very intense study, very well-structured study on tocilizumab. So we have been using toci at the appropriate time, at the appropriate time if it is used, it has kept many patients away from ventilation and possibly saved their lives. So this one factor of the fact that there is HRCT evidence of significant pulmonary involvement, and the fact that there is evidence of by way of either compromise of ventricular function, or whether there is evidence of tissue damage or there is tissue inflammation in the myocardium, please feel free to be aggressive, not only with steroids, but also with tocilizumab. So I think that these strategies have worked very nicely, in the sense today that we have very few patients who now have had to go on ventilators, and you know, all around India, the mortality has been less than 2%, but we have been proud at Medanta to have mortalities of close to 1%. So there is a huge change that has happened. Myocardium vis-a-vis our strategies from before and strategies now for in the presence of COVID. So what have we seen? Yes, in the early stages, we did see acute myocardial infarctions and acute stent thrombosis. As and when we discovered that this was a syndrome that was developing second to COVID infection, we embarked on early heparinization. Anyone who hit either with unstable angina, myocardial infarction, or just patients who had been on had stents, we would put them, and got COVID, we put them on heparin. This was reinforced by the fact that when those 40 autopsies were done in Italy, Bergamo, where they actually demonstrated the pathophysiology of death by way of inflammation in the vessels of all organs of the body, and especially of the myocardium, and that inflammation actually in the lungs blocked the vessels with clots, and similarly happened in cardiac. So we then recognized that the strategy that was adopted for heparinization early actually had saved many lives, and now with the new evidence from those autopsy in Bergamo, it only reinforced the fact that one should be very aggressive with heparinization. So having learned all these lessons, I think that today, very, very effectively, and if you can get revascularization done early enough, we are seeing the evidence very successfully that there is return of muscle. But those people who have been stented outside of the window, their myocardial recovery or myocardial salvage is still not very good. So I think that that is to be in that particular window when somebody is over 18 to 24 hours from a myocardial infarction, we have to be questioning ourselves whether we should be doing intervention at that stage or and whether what benefit we'll give them. So I think all this stuff has to be put in perspective. I hope I've been able to share some of my thoughts. If there are any questions, I would just add my own field is to say when we started and when I came back from the US, 20% ejection fraction was not even considered a surgical candidate in India. We started a very long series. We started with 9% mortality, and today is less than 3% in the worst of cases. So there is a lot of ground we have covered in our surgical practices also. And if you study them preoperatively better, your target organs, your target myocardial segments, you will do much better. So we do a very extensive mapping by way of MRI and PET scans. And if the worst of cases, I can show you that we have over 3,000 cases in this group, which we have done, and now we are it's become a standard procedure in our institution. So that's the lay of the land as far as cardiac disease is concerned. It's medical, it's interventional and surgical therapies. So with that, I will stop here. If there are any questions, I'll be happy to answer.
Yeah, thank you so much, sir. So in current era, how much is the role of a surgeon in acute MI setting?
As I said, very little in the sense that our colleagues have come to our rescue, actually. So, as I said earlier, there'll be many nights I'd be rushing out of the house, operating on people who were then in the middle of cardiogenic shock, and there was no way of making them salvaging them. But today, better than 97%, our colleagues can revascularize them, or the tissue is damaged enough that you will not help to operate on them. So that risk, okay, that's a very good question in the sense it opens up another stream for me. So if you look at it back in time, I remember while I was in New York, if we were going to operate on somebody who had a myocardial infarction, we would have at least a 6-week window where we said we must let the myocardium recover and then bypass them. Many studies we did over there, and then we discovered that in waiting for that 6-week window, many people got another MI or died. So over a period of time, as we went more further, and our confidence in early operation increased, we actually do not wait for any fixed time now. So the formula, the algorithm that we created is the anatomy, the presence of acute ischemia, and other comorbidities will determine whether we will operate in 24 hours, 36 hours, 7 days, but rarely beyond 7 days after an MI. So we don't wait anymore. We try to do it as soon as we recognize that there is myocardium at risk, which is significant, and there is evidence that there is continuous ischemia, then you must intervene. So today's strategy is according to that now. It's not that anybody who got acute infarct had triple vessel disease that you'd have to go in and bypass them. You don't need to do that anymore as an emergency. Even if rescue angioplasty has been done, then you continue to monitor them. If that rescue angioplasty has salvaged the life at that point, you will get a chance as a surgeon in the next 3-4 days to 7-8 days that you can revascularize them safely. But the only thing you need to be worried about in that group, because surgically we are doing 99% of our work off pump. So there is really no edema post like we used to see post pump. So there's no post pump syndrome at all. We do beating heart in left mains, in acute infarcts, you have it. And like I said, 1% of the time you do need to use the pump, you go on pump in the middle of it. But the point is that your ability to revascularize safely is quite good today. Or I would say near perfect if you are 99% success rate. But their arrhythmic management has to be absolutely precise. Their problem comes from arrhythmias post-operatively, starting from immediate after revascularization. So you're depending on myocardium that is already damaged, myocardium at risk, and the return of the ECG to what level your strategy will be aggressive or medium level according to that. So that's one thing that you need to be very careful about, that you don't lose patients to arrhythmia in the post-op period.
Dr.
Sir,
Priyan,
there is a contentious issue of dual platelet agents after angioplasty, and then if you have to operate very early, that always remains a question in a cardiologist's mind also, whether to stop or not to stop, how much is the risk of bleeding or thrombosis. So what is your strategy in this?
So this is risk-benefit ratio determined. You like to wait for each of the substances that you use. They have those 1 day, 3 day, 7 day window, 5 day window. We don't actually pay full attention to that if there is risk to life. I'd rather take the risk of bleeding and take all the blood products and whatever else we can use. And like I said, we do not have to use heparin to the level that we have to if you go on pump. If you can accomplish it without pump, where you have not done full heparinization, your bleeding problem is also less. So the point is, our ability to take risk with anticoagulants on board or antiplatelets on board has become much more aggressive than it was before. So our appetite for risk without compromising the patient's safety, by the way, our appetite has to be related to the success rate. But we are not hesitant anymore. If somebody is not going to make it, you go in and operate and then face the consequences later. But I'll tell you, 99.9%, if you're prepared well pre-operatively with all your products and everything, you'll do all right.
Thank you. Dr. Lochan, sir, anything from your side? Any other comment from Dr. Lochan, sir?
How are you, Pandey?
I am fine, sir. I remember the great days with you, and from the days that you started bypass and we were doing a angioplasty. Sir, you are phenomenally great, and the success is good. We always listen to you on TV now on the COVID and this, and from masterly inactivity in the coronary artery disease about 30 years back. Now we are with the complete activity and saving. I have not seen anybody dying of coronary artery disease now if we comes in time. And with the great expertise that Medanta and Indians doctors have, the coronary artery disease has totally revolutionized. Congratulations to you and to the medical science.
No, it's a pleasure. It's a pleasure to see both of you because we have been colleagues at some point or the other. That's great. And good to see you.
We have learned so much from you, sir.
No, that's great.
Can I ask one question, Dr. Priyan?
Please.
And a comment. We are quite happy that we do a triple vessel disease, culprit artery at the same time, and leave the rest of them, the surgeon, to do it a later date, stabilize the patient in a better way to do it. Of course, we are doing it. I understand your argument, and you did very nicely. I had one question that because sometimes ischemic MR happens with this myocardial infarction, and what is your current advice? Because that's a very challenging situation, either VSD or MR. Of course, VSD you have to do it quickly, but what is your current advice or plan on this patient with ischemic heart disease, MI? And
Okay, no, very good question. Very good question. I'm glad you asked that because that I had not touched upon that. So, acute myocardial infarction, ischemic, is an emergency for sure. So, what you're saying is, again, there is a three factors here: the degree of or muscle damage in the myocardium due to the MI, and acute MR will usually occur with lateral wall or inferior wall.
That's correct.
So, what is the extent of the damage? Second is the point: what is the state of the anteroseptal wall? Because, in my opinion, the anteroseptal wall can be saved. Your patient has a better than 97-98% chance to survive. Acute myocardial acute ischemia leading to MR has to be dealt with together. And as so, if you tell me if I have a patient like that, I would put an intra-aortic balloon, stabilize it for 24 hours, study the anatomy, the extent of what the troponin is doing by way of ongoing ischemia, and what are my targets to revascularize. I will go ahead 24, 48 hours later to operate on that. The VST or ruptured myocardium, whether it is pseudoaneurysm or whether it's septal, you have to be weighed a little differently. Now, you people, our cardiology colleagues can go in and put in a device in a smaller vessels. But frequently, the VSD will occur in the distal septum near the apex, where it becomes difficult to actually place a device. So most of the time, you're actually forced to operate. And that is one thing that you can, but you must, at the same time, exclude all mushy myocardium. You know what biggest mistakes we used to make was that we used to think, oh, let's not take such big bites outside of the infarcted area, and then the patches would fall apart. Right now, we weave the patches into healthy muscle. So the technique of sort of repairing the VSD, no matter where it's located, has changed. And your outcome is good if your patch stays. Your outcome is terrible if your patch will detach itself. So that's why a recurrence of a VSD post repair is a very bad sign, and you lose 25-30% of those patients. So I think that if you have one attempt, and in that one attempt, if you can do it right, I think there is a very high chance, better than 95%, that you'll save the patient.
Thank you very much,
Thank you,
Dr.
sir.
Shyam. Once again, it has been excellent learning session with you and one-to-one talk. I think it was very close than actual meeting, but I'm very impressed the way it has been conducted, and we learned a lot, very important issue. Thank you very much, sir, for this
Thank you, sir.
excellent talk. Thank you.
Thank you, sir.
No,
Thank you.
so nice of you, and hopefully within the next few months we shall be able to do these activities in real time, which is also
Yes.
fun. And this is also
Yes.
good because you don't have to take the trouble of traveling, but traveling is fun also. It's an important part of life. So thank you all very much. I really appreciate it, Dr. Mittal, and good
Thank you,
luck,
sir.
and have a great conference.
Thank you, sir.
We are now in the beginning of a second wave in India where we are fighting it tooth and nail. So I'm just going to go hang up on you and go on a national seminar of actually a TV discussion. There's a three TV discussion on this subject right now. So I'll beg your leave, and thank you
Thank
for
you.
inviting me. Let's catch up again. Thank you. All the
Thank
best.
you very
Thank you,
much.
sir.
Good night, sir.
Thank you. Good night.
With this, we move to the next part of the symposium, which is a very important message, which is we are going to listen from Dr. Abhay Pandey, who has been here in UAE for a long time. And those who are new in Dubai may not be aware that Dr. Abhay Pandey was the first interventional cardiologist in UAE who started in private hospitals intervention at Al Zahra Hospital, Sharjah. And that was the beginning of new era. Before that, service being offered by the government hospitals, but this was the first hospital which has done it. And Dr. Pandey has been had an important role. Another thing is that recently we had a World Women Day, and so he's talking on a very important topic, which is how the world women heart disease is different, and he can guide us and let us know some, because people think that it's just a different person like a male and female, but there are some minor differences which makes the difficult decision making and planning the treatment, and Dr. Pandey will enlighten us. Dr. Pandey, please.
Thank you. Thank you. Good evening. I want to highlight one important aspect which affects 50% of the world population, the coronary artery disease in women, which is a different ball game. Cardiovascular disease kill more women annually than all forms of the cancers, chronic lung disease, pneumonia, diabetes, and hypertension. The women are roughly 10 years older than men when they present and have more comorbidities. Young women also develop coronary artery disease and have a worse prognosis than men. Women are more likely to wait before presenting to the medical attention. The 1 in 2 women will die of heart disease or stroke as compared to 1 in 27 who will eventually die of a breast cancer. Cardiovascular disease ranks first among all disease categories in hospital discharge for women. 41.3% of all female deaths in America are from heart disease and stroke. 38% of women, compared with 25% of the men, will die within 1 year of getting a myocardial infarction. Uh, the alarming facts which are for in women are that smoking is now increasing in women, prevalence of obesity is increasing, 30% of the women report no regular physical activity, 52% of the women who are more than 45 years have hypertension, 40% of the women above 55 years have elevated cholesterol. Uh, Women lack understanding of their risk. That is a very, very important point. Only 8% of the women in America believe that heart disease and stroke are greatest threat to women. Women lack understanding of the signs and signals of the heart disease or myocardial infarction. The diagnosis of heart disease presents a greater challenge in women than in men. The significant differences exist between men and women in the clinical presentation of the coronary artery disease. Myocardial infarction is more often an initial clinical picture in men, whereas angina is more frequent initial clinical picture in women. Women with established coronary artery disease have a higher short and long-term mortality rates than myocardial infarction. After myocardial infarction, women are twice likely as compared to the men to have congestive cardiac failure, recurrent angina, and recurrent myocardial infarction. When women suffer a myocardial infarction, their outcome is substantially poorer than that of their male counterparts. Prevalence and consequences of the heart diseases in women are often underestimated, and this particular factor has to be understood by the medical community as well as by the people in general, so as to prevent heart disease and mortality in many women. The treatment patterns also differ in women as compared to the men. Physicians' interpretation of patient symptoms and patient assessment of the risk of symptoms may contribute to the gender difference in outcome. Women are significantly less likely to receive aggressive management that includes cardiac catheterization and revascularization procedures. Non-invasive cardiac procedures like treadmill tests have increased likelihood of false positivity and negativity in women, and therefore has to be reported and further investigated carefully. About 6.6 million American women have heart disease. Heart disease has no quick fix. Even if special procedures like angioplasties are performed, heart disease will worsen unless there is lifestyle changes and medications. About 35% of the women have heart attack and will die within 6 years. About half of the women who have heart attack will be disabled with cardiac failure within 6 years. The women with heart diseases, the main problem is that they do not present with typical symptoms. They have many atypical symptoms. They may present with new episode of fatigue. They may present with shortness of breath, insomnia, indigestion, or just an anxious feeling or depression. In a study of 515 women with myocardial infarction, chest pain was absent in 43%. The most common symptom in this group was dyspnea in 58%, weakness in 55%, fatigue in 43%, and prodrome was like fatigue in 71%, sleep disturbances in 48%, dyspnea in 42%. These women who presented without chest pain were more sick. They fared worse. They had more diabetes. They had later presentation. More class 3, class 4 presentation was seen. They had more NSTEMI than STEMI, and they received less time with therapies. They were given less antiplatelet medication. Heparin use was limited. Beta blocker usage was also limited in patients with women who did not have chest pain. This another important factor. Though sudden cardiac death is more common in men, the women who have sudden cardiac death, they do not have prior symptoms, 63% versus 44%. The risk factors in women are also different. Menopause, younger women have less heart problem as compared to myocardial infarction as compared to the postmenopausal women. Obesity, high triglycerides, metabolic syndrome, sedentary lifestyle, collagen vascular diseases, chronic kidney diseases are more common risk factors in women. Pregnancy related factors are very important. Those women who suffer preeclampsia, eclampsia, or those who have gestational diabetes, stillbirth, multiple miscarriages, they have more incidence of coronary artery disease. And therefore, these patients who undergo preeclampsia or eclampsia should be followed up and screened for development of coronary artery disease. Women who have cancer treatment, those who have depression or stress, those who have history of trauma or abuse have more incidence of coronary artery disease. Another important thing, the low HDL is more predictive of a coronary artery disease than high LDL in women. The LPA can be more predictive in younger women as compared to the men, and a high triglyceride level, especially more than 400 milligram percent, is more predictive for coronary artery disease development in older women. Diabetes is very, very important both in men and women, but more in women. In females, the diabetes increases the risk almost double. And similarly, smoking. Particularly in the Western world, 50% of the coronary events in women is associated with smoking, and the risk of coronary artery disease is elevated even with minimal use of smoking. Women who smoke, they have 6-fold increased risk of myocardial infarction when compared to 3-fold increase in men. This risk was higher for women smokers than men, regardless of age. The pregnancy-related factors also include failed stress tests. Then, as I have already illustrated, preeclampsia. The women who have preeclampsia have 3.8 times more risk of developing diabetes, 11-fold risk of developing hypertension requiring treatment. Those women who have gestational diabetes, 70% develop diabetes mellitus within 5 years. And all these factors increase the likelihood of coronary artery disease. So also is menopause. Diagnosis, the women are less likely to be referred for further evaluation, even if they have a positive stress test. And the women who have positive stress test have a higher incidence of myocardial infarction or death in these patients. Similarly, intervention treatment, the women are less likely to be referred for intervention treatment as compared to the men. Many studies have proved this factor. There is a high complication rate in women when they undergo intervention treatment. The women have smaller arteries, they have more bleeding. But women who undergo intervention have a better outcome than women who do not undergo PCI or any other intervention. The higher peri-procedural rate of complication is there, but there is a better long-term survival in than in men, in women who undergo coronary interventions, and they should be immediately referred for interventional management. The bleeding, women have more bleeding than men. This is secondary to the technical factor and medication use. When we consider this bleeding, the PCI has got same efficacy as in men, but they have higher bleeding and higher mortality. The other cardiac causes of chest pain, women have more higher incidence of syndrome X or microvascular disease. They have more incidence of coronary artery dissection, particularly in peripartum period, more incidence of myocarditis. They have more stress-induced cardiomyopathy. So the take-home points. Take-home points are coronary artery disease and coronary vascular disease are by far the biggest health risk for women. The awareness is still less than it needs to be. The prevention can reduce the risk of coronary artery disease, and screening programs are available. Women can present differently and do worse when they do. Women are referred less often for appropriate testing and treatment. Women can have more complication from treatment, but still fare better than those without treatment. And the special consideration should be given to the complication during pregnancy, menopause, and comorbidities. To increase the awareness of coronary artery disease in women, the American Heart Association has started a Red Dress Pin program. This is to increase the awareness, and it should be followed all over the world, as the coronary artery disease affects 50% of the world population. Thank you.
Thank you very much, Dr. Pandey, for elaborate topic cover which you have done, and it has been various aspects you have discussed in practice. And with this, we will come back to your some questions later. And but just I'll make a comment that I think that there is a inertia in females. Probably they think that ischemic heart disease is the disease of male. That's why probably they don't appear to the scene early. So with this, Dr. Pandey, thank you very much. And maybe at the end of the talks, please be here and we will be continue with the discussions. And with this, we end this talk. And Dr. Brajesh, can I ask you to introduce the next speaker, please?
Sure. Thank you so much. So our next speaker is Dr. Peter Otasevic, who is a professor of medicine and is a consultant interventional cardiologist. He is in University Medical School, Serbia. He's a wonderful person. We have met several times. He's a good speaker, and it is my pleasure to welcome him to deliver a talk on chronic coronary syndrome, only a new term, or also we have to think differently. It's a new approach. So, Dr. Peter.
Hello, everyone. It is a great pleasure to be with you on this great meeting organized by Dr. Brajesh Mittal. Term chronic coronary syndromes is coined by the 2019 European Society of Cardiology Task Force that was gathered to write the new guideline of the condition previously known as stable coronary artery disease. It's a little wonder that this change in terms sparked the fierce debate in cardiology community regarding the true novelty of the approach. When we look at the other side of the Atlantic, we can see that ACC and AHA guidelines for 2012 and their update in 2014 still call stable angina or stable ischemic heart disease, so no chronic coronary syndromes for the Americans. If we turn to Europe, UK or NICE guidelines that were published in 2010 and updated in 2020 still call stable angina or stable chest pain. Again, no chronic coronary syndromes for the English. The rationale for the new term for the task force of the European Society of Community is that patients with coronary artery disease may have different prognosis. Patients who have truly stable symptoms or patients who were revascularized can have really low annual mortality or fatality rates in the range of maybe of 1 to 2%, which can rise several folds for the patients with recent onset acute coronary syndromes or patients with suboptimal lifestyle modifications or patients with inadequate medical treatment. So what are the novel concepts in the ESC 2019 guidelines? Of course, the major novel concept is that stable angina is called chronic coronary syndromes, and the rationale for the change of terms, at least for the people on the task force, is that coronary artery disease is a dynamic process of atherosclerotic plaque accumulation and functional alterations of coronary circulation that can be modified by lifestyle, pharmacological therapies, and revascularization, which result in destabilization or regression. In the current guidelines on chronic coronary syndromes, there are different clinical scenarios for the different type of patients. So the first type of patient that is described in these guidelines is the patient with suspected coronary artery disease and stable anginal symptoms and dyspnea. The second group is patients with new onset heart failure and suspected coronary artery disease. The third group is asymptomatic or symptomatic patients with stabilized symptoms less than 1 year after an ACS, so patients with recent revascularization. The fourth group is asymptomatic and symptomatic patients more than 1 year after initial diagnosis. The fifth group comprises patients with angina and suspected vasospastic or microvascular disease. And the final group is asymptomatic subjects in whom coronary artery disease is detected and screening. When we look at the changes in major recommendations in the guidelines from 2019 as compared to guidelines from 2013, there is really no mention of this specific patient subgroups, but rather modest downgrade of some points regarding the exercise ECG testing, which was downgraded a bit, and some upgrade of some sort of medications and the approach that includes fractional flow reserve or corner flow reserve techniques. Just to clarify a bit my point that coronary chronic syndrome is really just a new name and not a new approach, I will address only 2 points, such as role of the coronary computed tomography coronary angiography in the diagnosis of coronary artery disease and indications for revascularizations. So let's go first with the role of CTCA. If we look on the diagnostic algorithm that was proposed by ESC task force, we can see that there is equipoise between coronary CT angiography and testing for ischemia in patients with low to moderate probability for coronary artery disease. This is firmly set as the new major recommendation, which gives us a grade 1 recommendation for the initial choice between coronary CTA and myocardial ischemia testing. And the guidelines suggest that we should choose one of these tests based on local expertise and the availability of testing facilities. However, there is a wealth of data suggesting that CTCA might be superior to imaging, to other imaging modalities in the prognosis of patients with coronary artery disease. And I will just show you data for the 5-year follow-up of Shakeheart study. Shakeheart study was basically a study that included more than 4,000 people, and they were randomized based on the use of CT. The patients were randomized on the group with the use of CT coronary angiography and the group based on standard of care diagnostic testing. After 4.6 years, there was clear advantage of coronary CT coronary angiography approach because the patients who were initially enrolled in this group had more than 41% reduction in death and myocardial infarction as compared to patients who had standard of care treatment. Interestingly, there was no difference between the groups in the incidence of coronary angiography, PCI, or myocardial or surgical myocardial revascularization. The sole difference between the group was the presence of preventive treatment, which was much higher in the patients who received CTCA as the initial diagnostic test. This was recognized by the ACC position paper on CTCA in the evaluation of stable coronary artery disease, and this position paper clearly states that use of coronary CTA should be default test for evaluating patients with stable chest pain and low to intermediate pretest probability of obstructive CAT. That's the ACC position paper 2020, clearly different from the current ESC guidelines. How about the NICE guidelines? NICE guidelines from 2016 update clearly favor CT coronary angio as the diagnostic test of choice for people in whom stable angina cannot be excluded by clinical assessment alone. Now let's switch gears and see what we have in store for the indications for revascularization in these patients. As you know, there has been a major decrease in the incidence of coronary revascularization in the United States in the last 15 years or so. So generally, there has been a twofold decrease in the incidence of percutaneous as well as in the incidence of surgical myocardial revascularizations. When we break down this data based on clinical presentation, we can see that the incidence of both percutaneous and myocardial revascularization actually increased in patients presenting as myocardial infarction, either with or without ST segment elevation, but there has been a dramatic decrease in the revascularization procedures in the patients who presented as stable ischemic heart disease or unstable angina, both for PCI and myocardial revascularization. This is due to the advent of effective new medical treatments, as well as on a number of studies indicating that actually optimal brachytherapy is not worse than PCI for patients with stable coronary disease. I will just remind you on the data from the COURAGE study, which was done in early 2000s. Basically, patients were divided into groups based on the fact that they received medical therapy or PCI for the significant coronary stenosis of the major epicardial artery based on coronary angiography alone. As you all know, over the period of 4.6 years, there was no difference in the composite endpoint between the groups, nor between the individual endpoints such as overall survival, survival free of ACS, or survival free of myocardial infarction. In the extended follow-up of these patients, 12 years approximately, again, no difference in the survival between patients who were randomized on percutaneous coronary intervention and optimal medical therapy alone. If we look on COURAGE data regarding the quality of life, we can see that quality of life is clearly better in patients who received PCI in the first 2 years following the PCI. But from then onwards, there is no difference in the quality of life between the two groups. When we look at the 2019 ESC guidelines regarding the revascularization for patients for chronic coronary syndromes, we can see that these guidelines generally recommend revascularization for patients who have large area of ischemia, who have diameter stenosis more than 90%, or hemodynamically significant stenosis as assessed by fractional flow reserve. But that was before the ischemia trial was published. The first results of the ischemia trials were published in 2019 on the ACC annual meeting, but the full text was published more than 1 year ago in April 2020. As you can recall, the ischemia trial included patients who had moderate or severe ischemia by some mean of testing and excluded patients who had heart failure defined as NYH class 304 or ejection fraction less than 35%. To be enrolled in ischemia trial, patients needed to fulfill some additional CCT eligibility criteria, such as 50 to 70% stenosis on a major epicardial vessel, and the patients were excluded if they had a significant stenosis of the unprotected left main. After 3.6 years in average of follow-up, there was no difference between patients randomized on conservative or interventional treatment. Definitely no difference in the composite endpoint of cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. Regarding the quality of life, it appears that patients who are truly symptomatic and have daily or at least weekly anginal attacks may benefit for the revascularization procedure as compared to patient randomized to optimal medical treatment. Based on ischemia trial results, there was a joint statement by European Society of Cardiology and European Association of Cardiothoracic Surgeons that due to new recent data, revascularization guidelines need an urgent update. Therefore, 2019 chronic coronary syndromes guidelines for revascularization should be taken with a grain of salt, at least for this point. Therefore, ladies and gentlemen, let me conclude that my humble belief is that chronic coronary syndrome, it's only a new name for a well-established entity of stable angina or stable ischemic heart disease. Thank you for your attention.
Thank you very much, Professor, for your excellent introduction to the old topic which we have been dealing and in the new information. And it's not just the new name, but you have told us of the data to understand this a little better. With this, we'll come back to you for some questions at the end of this third talk. And with this, I will introduce our dear friend, Dr. Professor Gupta, who has been with us for a long time in UAE, and He has been in Drake Hospital University was as a professor. He was teaching, and he was consultant in the uh, government hospital, Ovisal Safe Hospital in Russell Khema, and he has been interestingly from the My Medical School, alma mater. So I would welcome Dr. Gupta, who has left us for UAE but is still very active, and he is very knowledgeable. He's always very well read about the latest literature, and he presents the data very elegantly and dissects it well so you can understand. So next, I will ask Dr. Gupta to tell us what is the thrombolysis and invasive approach in the current era. Dr. Gupta, please.
Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Brajesh Mittal to be part of this wonderful virtual conference. And I am going to talk on thrombolysis and pharmacoinvasive approach in the current era. And what I have planned in next 12 minutes, current role of thrombolytic therapy, current role of pharmacoinvasive therapy, and how to integrate both of them in STEMI care. And so what's the key in STEMI care? If you really analyze, it's a timely reperfusion. Whether you do primary PCI or thrombolytic therapy or a combination of thrombolytic therapy followed by PCI, that's a pharmacoinvasive therapy. Why time is the key? Because the PCI have to be performed within 60 to 90 minutes, and it should not exceed beyond 120 minutes even when the patient is transferred from a non-PCI capable hospital. Because and if you are thrombolizing, then of course FNC to thrombolysis should be less than 10 minutes. Time is muscle and muscle is life. You lose muscle and increase mortality, and that's why the time is the key. And it's clearly depicted in this slide that as per ESC guidelines, if time to PCI is less than 120 minutes, then the primary P still holds as the most preferred strategy. But if it is not feasible and it is going to take beyond 120 minutes, then of course you have to thrombolize within 10 minutes, and then you have to transfer the patient within 2 to 24 hours, either by a routine PCI strategy or by rescue PCI. That's the basically pharmacoinvasive, in which you thrombolize and then send the patient to the PCI center within 2 to 24 hours, irrespective of reperfusion. And why it is still relevant in the current era, thrombolytic therapy along with pharmacoinvasive approach, because this is the registry across the Gulf. That's a Gulf Race 3, in which all the Gulf countries participated, including United Arab Emirates. And if you see here, the primary PCI was performed only in 46% of patients, and 39% patients received thrombolytic therapy. But I want to highlight the most unfortunate ones were the 15% who did not receive either of them. So that's really unfortunate, and we have to resolve that nobody in a STEMI should remain without reperfusion therapy, either of them. Just if you analyze, there are more than 25 cath labs in Dubai, but how many of them are offering 24/7 round the clock primary PCI? And that's why both thrombolytic therapy as well as pharmacoinvasive approach are still quite relevant in the current era. Of course, the fibrillary therapy has got its own advantages. It is easily accessible, universally available and affordable. It can be given by single bolus injection. It can be administered by any properly trained healthcare provider in the pre-hospital setting. Goal is to thrombolyze as early as possible, preferably less than 10 minutes. Of course, those patients who are beyond 75 years, the TPK has to be reduced by the dose of tenecteplase has to be reduced by 50%. And the most important thing is the thrombolysis is clearly better than no treatment. So if you are unable to perform the primary PCI, you should offer immediately the thrombolytic therapy and pharmacoinvasive approach, because at that point of time, what matters is quickly reperfusion than deciding which is more relevant. Of course, the fibrinolysis has got its own limitations. It has got frequent contraindications and effectiveness in inducing reperfusion, the risk of ICH, although it's less than 0.8%, efficacy declines as the duration of ischemia increases, and the fibrolytic therapy remains an important adjunct to primary PCI if it cannot be performed in the stipulated time period. And of course, thrombolytic therapy, the most preferred modality is the pre-hospital fibrinolysis, which is safe, reasonable, and it can be performed by skilled trained paramedics, nurses, or physicians under strict protocols. Of course, all of them have to be trained with the protocols, which must include thrombolytic checklist, 12-lead ECG interpretation and transmission, training in ACLS, 24-hour availability of medical direction, and it is utilized when the transport time is beyond 30 minutes. And the preferred agent are tenecteplase and retiplase, and it should be accomplished in less than 10 minutes. And this is again ESC guidelines say if you are utilizing thrombolytic therapy, it is class 1A indication in STEMI, preferably in the pre-hospital setting. Therefore, in cases where primary PCI cannot be achieved in due time, on-site process and transferred for CAG and PCI, 2 to 24 hours is a reasonable alternative. That's a pharmacoinvasive approach, which was initially tested in a stream trial, where both pharmacoinvasive as well as primary PCI were confirmed, and there were no significant difference either in efficacy or safety when the tenecteplase dose was reduced to half in patients beyond 75 years. And that's what the ESC guidelines recommend, that after fibrinolysis, all patients should be referred to PCI capable center for PCI. And that's the strategy they have labeled pharmacoinvasive. Whether it really works or not, we have got data. This is a paper from Mark Jubaid. We are all familiar with this name, and in which across the Kuwait, it's a prospective countrywide registry in which the primary PCI was confirmed. Primary PCI was compared with the pharmacoinvasive approach, and this is the study from Brazil, in which in the Mexico City, both the approaches, primary PCI and pharmacoinvasive, were compared. And both the studies, they have clearly concluded that when you think that the primary PCI cannot be performed in a timely fashion, the pharmacoinvasive approach offers a safe and effective reperfusion option, and it should be utilized whenever it is needed. Now, how to integrate thrombolytic and pharmacoinvasive approach? So every city, every region has to evolve its own STEMI regional care. When I was working in ROC, of course, ROC had one non-PCI capable hospital,
there's IVHO, and then we have a nearby private hospital. There is a cath lab, and a little away, the government hospital, there is a PCI capable. So what we suggested is that we have to have a series of workshops in which the all stakeholders should participate and communication lines should be established among. So emergency medical services, non-cath lab hospital and IVHO, primary healthcare, private clinics, and cath lab hospitals as ROC and SKSH all should be involved in this series of meetings where they can involve how to develop the regional STEMI care so that nobody should be without any reperfusion delay. But there were a lot of issues in integration, government versus private. Even within the government, there is a different systems, different payment systems as cash, insurance, and charity. Better integration of primary healthcare, private clinics, and hospitals are required. Networking of hospitals with emergency medical services are required. Lack of training of healthcare professionals about the STEMI care. Training of emergency medical personnels, both EMT and ambulances. Creation of protocols and pathways for integrated STEMI care. Dedicated transport pathways to avoid traffic delay, and community awareness programs involving print, digital, social media campaigns, and creation of cardiac rehab facilities. So, ladies and gentlemen, we have to transform our STEMI care, which at the moment is highly fragmented, to a more streamlined, well-integrated STEMI network and care. We should ensure adequate reperfusion within the time window to each STEMI patient. So I would conclude by saying that the pharmacoinvasive approach along with thrombolytic therapy is a safe and effective reperfusion option in situation where primary PCI cannot be performed in a timely fashion. And both these approaches have to be integrated in the regional STEMI care by utilization of emergency medical services and some initiatives as Stand for Life and Mission Lifeline to improve the quality, adoption of universal healthcare insurance, which should cover life-saving procedures as primary PCI in STEMI patients, dedicated transport pathways to avoid the traffic delay. So we have to establish an integrated, streamlined, well-organized regional STEMI network, but this concept yet to catch the imagination of our healthcare authorities, and this conference is the right step in that direction. Thanks for your kind attention, and thank you.
Thank you, Dr. Gupta. It has been an excellent hearing you again, and as always, you were very crystal clear and presentation was to the point, and as always, it has been our experience to listen to your talk. So with this, we come to the close of this symposium, this particular part, and I would just comment on this Professor Oakley's presentation, and he gave us a very good insight that we should refrain ourselves as interventional cardiologists from oculostenotic reflex. We should not see the stenosis and jump on putting the stent. There are data suggesting that we can still do a good job if a conservative management is done in a chronic stable disease. And with this, Dr. Pandey has very nicely presented the data on women, and incidence of the complications are higher than as compared to male. So would you add on anything else, Pandey, on that, Dr. Pandey? Can you unmute it? Can you unmute
The
it?
main problem with the coronary artery disease in women is lack of awareness. There are subtle differences which people need, the society need to understand. If in a given family the husband gets chest pain, he is rushed to the hospital. If the woman gets a chest pain, she first uses some pain balm, something, and she's delayed. So a great awareness has to be increased. The PCI or any intervention will definitely improve the survival of this. However, early recognition of difference between the male presentation and female presentation should be highlighted. There should be a campaign to make the people aware that the commonest cause of death in women is heart disease, and it can be prevented if, or at least delayed.
Dr. Pandey, that's a very interesting point. If I've summarized your thing, I liked one line of your presentation that was less number of women reaches the hospital, but whosoever reaches the hospital, they have a better survival chance if they have gone and PCI. So that was a very important message which you have given us. With this, that Dr. Gupta, I think your talk has been very practical, and we always confused whether thrombolysis is out, but it is not out. You have shown very clear data that it is not available in many parts of the world, and still, and the stream data shows the results are not very far in terms of the revascularization success rates. I understand that now, after the finished trial, half dose therapy of thrombolytic and PCI is that out. And do you want to add anything else, newer therapy we need to discuss in this regard?
Yeah, I think what I highlighted is there are two aspects. Both the therapies, thrombolytic therapy and pharmacoinvasive, they are very much relevant. They are very much here, and they will remain here for a long. Because, and the second most important thing is the integration of all the reperfusion therapies. But unfortunately, the problems are same. When I was in UAE, I was facing the same problem, and the same problem are in India. Local institutions, local problems. So it's very difficult to integrate. In fact, I raised this issue in local CSI Indore, and tried so many things that the whole STEMI care of Indore can be organized. But the problem is private institutions, every institution wants to have their own protocols, behave in their own way. So it's really very difficult. But still, the most important thing is lot of patients are still are not getting any reperfusion. So that portion should not persist. We should try to remove at least that portion. So we are trying to educate that as soon as the patient gets a chest pain, should report to the nearest hospital. ECG can be by WhatsApp, can be sent to the nearby where a cardiologist or physician trained cardiologist is available. So we are doing a little bit things to integrate, but still, in my feeling, it's a Herculean task because of the different interest and different modality of thinking. But we have to work on, and we have to provide the best possible to our STEMI patients.
Thank you. Dr. Peter, if you are online, I have one important question to ask from
Sorry,
you.
Dr. Peter is not online, but you can give your comment on his presentation.
Okay, so on the whole, this is the new things which you have mentioned about the approach to this treatment. One is that we have been always relying very much on the non-invasive testing for the stress test, for example. In the recent guidelines, it has been downgraded. Earlier, we used to send each and every patient whom we suspect angina to put on a treadmill. And I think the reason I'm going to discuss that in my presentation, why we don't do it. So I won't disclose that because I'm sure you will be attending that meeting. But we learned that newer modalities treatment has changed, like newer drugs, like ronalazine, ivabred, nicorandil was in past, and procoron, things like that, they have been added in our armamentarium in addition to beta blockers, nitrates. And I think that has drastically changed the symptomatic outcome in the patient of the ischemic heart disease. So our aim, as we know that ischemic, all the patients, when we do intervention, we are not prolonging their life, we are controlling their symptoms. So in the same way, if one can achieve that adequately with non-interventional means, that should also be applied before just jumping to the intervention.
Yeah. So I have a question from Dr. Pandey. obviously women are lagging behind in terms of treatment provided. Their symptoms are often ignored and often delayed in the treatment. So this is about the therapy part. How and what efforts and what extra effort should be done as a primary prevention for the women? Because until menopause, women think they are completely protected, which is not the case exactly.
Correct.
Somewhat protected. So what advice extra would you give for primary prevention? And we should have our efforts in this direction.
One is taking care of the lifestyle changes, awareness of the disease, and that is very important. That awareness with the like in Seattle, they had Seattle Heart Watch. They had made an awareness campaign for the heart disease in women. The American Heart Association is doing the same job. The rate in this similar attempt should be done. People should be told. Even the first step is to educate the doctor community, because doctor community itself is not properly aware of this fact that women and the women themselves as well as the doctor community, they underplay the symptoms. So the symptoms should be given recognition. They should be told that you may not have the same symptoms as the men. That is important. Taking care of all the risk factors, diabetes, obesity. The obesity is on increase, particularly in UAE. About 36% or more are obese. They don't do exercise. Smoking, and particularly shisha smoking in UAE, in Gulf area, people feel that shisha smoking is safer. On the contrary, it is worse than cigarette smoking, and which should be highlighted to the people. They should undergo regular testing, and even if they get a normal certificate, that is better than getting up a myocardial infarction or coming up late with heart failure and other problems. So the most important thing is awareness in the community, awareness in the doctors, and they should be given the proper treatment at proper time.
Thank you so much. May I request Dr. Lochan to please conclude this session?
Just I want to have just one comment.
Okay, Dr. Gupta.
Yeah, I think we have to integrate and collaborate more with our obstetricians and gynecologists colleagues. Cardio obstetrics is a new modality which is coming up. We have to establish well women clinics, because the women during pregnancy, they basically encounter obstetrician and gynecologist. Those who have suffered from preeclampsia or gestational hypertension, those who have developed gestational diabetes, they are at high risk of developing not these risk factors, but more of the heart attacks and strokes in future. So we have to collaborate with our obstetric and gynae colleagues, as well as we have to establish well women clinics, and especially highlight around perimenopausal and postmenopausal. At that point, there is a constellation of cardiovascular risk factors, so they have to take care at that point of time.
Thank you very much with all the speakers and who has given an excellent job in this symposium and brought out some important points from the current knowledge, updated the newer trends and new ideas which could be included in the practice. With that, we come to the conclusion of this symposium, and I will thank all the speakers once again, and Brajesh, Mittal, for organizing such an excellent meeting and for a learning experience. Thank you very much. We can
Thank
move
you
on.
all.
Thank you so much.
Thank you.
Thank you, everybody. Thank you. Please stay on for as an attendee and give your valuable inputs. Thank you.
Sure.
Let's move to the next session. And we welcome our moderators. We have here is Dr. Rajiv Gupta online. Dr. Rajiv Gupta is not seen here. We see Dr. Chavi Mehra. Good evening. Welcome to the port.
Good evening.
We also have Dr. Virendra Mishra, one of our speakers here. We are waiting for Dr. Selvin Joss to join and Dr. Rajiv Gupta to join as moderator. So first we will start with an intro video and then we go forward with the first introduction for Dr. Virendra Mishra. So organizers, can you take it forward? Yeah. Okay. So I think our other two moderators are not yet here. So I will take this privilege to introduce Dr. Virender Mishra. He is a wonderful senior friend and he's a great speaker. He's a prolific cardiologist. Dr. Mishra is working in Burjeel Hospital, Abu Dhabi. And at a short notice, he agreed to take on a very complex topic. So let's hear from him. Organizers, can you please play his video?
It's very nice to gather again once on this very nice conference platform, Shakeheart 2021. I would like to thank to organizers as well as would like to thank to Dr. Brajesh for inviting me to share some experience of post-COVID MI. Is it real? My name is Virender Mishra. I am from Abu Dhabi. And as we all know that we have passed from the COVID-19 pandemic, which has involved 200 countries, nearly 125 million cases, out of them 2.5 million died. Just before going to the detail, we should know about the life cycle of this virus and how it is going to affect our human cells. As we know, coronavirus has got single-stranded RNA virus, which have 4 proteins, envelope proteins, and S spike proteins, and membrane proteins, and nucleopeptide protein. This nuclear virus is important because it is a need to these proteins, especially spike protein, to attach to the human cells. And this is the life cycle of coronavirus, COVID-CoV-2. This can affect our cells only by 2 ways. First, the spike protein has to attach to the ACE2 receptor, and then this ACE2 receptor spike protein combination has to be primed. This priming usually done by the TMPRSS2 protein, which is also there on the cell surface. And then whole this complex can enter to the cytoplasm and replicate the virus. This replication continue with the help of RDRP protein, and the other 4 proteins are manufactured by Golgi apparatus and endoplasmic reticulum here, and these 4 proteins then they combine and form the packaging of the new virus and then exocytosis. Why this life cycle is important, as our treatment is directly affecting the life cycle and preventing the human from this virus. Like for example, chemostat directly block the priming by TMPRSS2 of this virus and preventing it to enter. Similarly, the hydroxychloroquine stops the endocytosis cycle, which is a combination entering this virus into the cell with the combination and priming with cathasprin and cathasprin S. Can also have coronary spasm or microthrombi by cytochrome storm. Interestingly, cardiac myocyte do not have TMPRSS, so they cannot prime this virus complex. So they use another mechanism because they have cathaspin B and cathaspin S. So they come with this entry by the endocytosis. We see that these patients, when they have acute evidence, they secrete the high troponin, and then if they end up with acute MI, go to the STMI protocol, or they cause myocardial injury, do the echocardiogram, ECG, and other MRI to find out and go for the treatment of accordingly. This is very interesting publication. This publication has come by Dr. Shripal Bangalore from New York, published in New England Journal of Medicine. He published this case of series of 18 cases of ST elevation myocardial infarction with COVID-19. Evidently, these patients have shown inflammation in the myocardium, also shown the thrombotic state, which has shown the injury pattern with acute MI, and lung involvement, respiratory, which also been advanced by the ischemia shown by the stress MRI. And these patients with MRI has shown nearly 40% to 50% patients recovered from COVID. This is another publication in European Journal of Heart, recently published in 2021, that late gadolinium enhancement was present nearly in 49% of cases. And there was subendocardial and transmural gadolinium was in 16% and subepicardial in 19%. 9 patients can be demonstrated even at later time inducible ischemia, and cardiac magnetic resonance identified into total cardiac abnormality in about 54%. Non-ischemic type in about 26%, and ischemic type infarction or ischemia in about 22% of type. Those who were labeled normal, they were about 46%. And interestingly, out of these 46% patients, when they were acutely admitted, 51 of them has got demonstrable pulmonary embolism. They were follow-up. These are the images which is shown by the CMR, bright red color with the white blood in the MRI finding. And when these patients were later on subjected to the coronary angiogram, shows blockage of the coronaries. And some of these patients has been investigated by doing the stress CMR and reconfirmed by doing the coronary angiogram, showing the blockage with signifies the stress MR findings suggestive of ischemia, ongoing ischemia in COVID-19 patient. This is one of the important study, pericarditis and myocarditis, long after the COVID infection, a study which is done 10 weeks after the COVID infection. And these were the healthcare workers, 139 healthcare workers who recovered from mild to moderate infection of COVID. And then their mean age is about 52 and 72% were women. 16% were previously hospitalized, were severe enough. And these changes were examined by ECG, NT-proBNP, troponins, and cardiac MRI. Isolated pericarditis was seen in 3%, with myopericarditis in about 11%. 73% shows altered immune cell count in the form of decreased eosinophil and increased CD4 and CD8 count. Pericarditis was always associated with CD4 and CD8 counts. These patients were followed up and then took about 2 to 3 months extra for their improvement from cardiac function. This is another study of post-COVID syndrome incidence and the risk factor in Mediterranean cohort study, where 277 patients recovered from mild and the severe form of COVID infection about 3 months, 2 to 3 months after the disease. And what they have found out that about 50% of them still have those symptoms, but those symptoms are mostly in the form of mild cough, dyspnea, shortness of breath, palpitation, headache, and many of them have shown involvement of, except the chronic admission or follow-up in ventilation or ICU, other parameters, none of them relate chances of post-COVID symptom. This is interesting study where COVID-19 patient cardiac injury implication of long-term surveillance and outcome in survivors. And in this study, what they have tried to show the mechanism, how these causing the injury to the myocardium. They say it could be an oxygen supply and demand mismatch, or could be an acute injury as an acute coronary syndrome, or thrombotic or embolic or hyperadrenogenic state. Probably also have a direct viral invasion causing the different thing, including the cytokine storms. They lead to myocardial injury as MI, microinfarct, ventricular fibrosis, atrial fibrosis, and they can end up in ischemic cardiomyopathy, non-ischemic cardiomyopathy, subclinical or systolic diastolic blood pressure, and can have different kind of arrhythmia. This is another very interesting publication, came in Canadian Journal of Cardiology, post-COVID-19 acute myocardial infarction rebound. What they have found that in acute phase of phase of COVID-19, which is depicted here as this black bar, this is the time with the acute period, which is in the March and April, early April, where they've observed that in 2020, this orange bar is 2020, blue bar is 2017, there is a decline in both acute coronary syndrome, myocardial infarction, or non-STMI, compared with the previous number. It is definite decline in admission, and then this has come back, rebounded after post-COVID period when the condition was normal and COVID was low and the incidence of myocardial infarction was much higher. Now, when they divided it by non-STMI and STMI, they observed that the non-STMI has a significant decrease and fall, which is depicted here by green bar. And in post-COVID time, it is the acute myocardial infarction which has come up again, admission. If there is a very interesting French study, which is in a French hospital, what they have observed that the same pattern of decrease in admission of acute coronary syndrome like NSTMI, STMI, but increase in out of hospital cardiac arrest, more than 50 to 57% increase in cardiac arrest. That indirectly says that probably these patients, those who are not coming to the hospital because of the fear of the COVID, because of the fear of that they might get the infection, they didn't go to the hospital and had a cardiac arrest at home, which is signified by this study. And once the COVID has come down, the admission has started coming in, shows the increase in flux of the admissions post-COVID. Another editorial came like COVID-19 pandemic, the preventing hospital myocardial infarction admission or preventing acute myocardial infarction itself together. And they have come out with the same finding that came from the California, where 43 million person week has been examined for the incidence of MI. And they say there is a definite decrease of 48% in the peak time of COVID. And what they have observed when compared with 2019, there is a decrease in COVID incidence when the COVID was at peak by about 50%, which has increased later on. Similar study also came from Italy, northern Italy, where they have calculated all COVID cases along with all the ACS cases during the peak time, STMI, non-STMI, unstable angina, and shows the same pattern of decrease in incidence or admission in the hospital during the peak COVID time. So in conclusion, 10 to 30% of the patient hospitalized with COVID-19 have evidence of myocardial involvement. These patients are associated with higher morbidity and mortality. Common cardiac involvement are in the form of myocardial injury or myocarditis, pericarditis, and the other presentation is as arrhythmia, ACS, and thromboembolism. In children, wherever it is affected, the myocardium has shown that hyperinflammatory shock and Kawasaki-like disease. Although the myocardium has got the ACE2 receptor, but it does not have the TMPR SS2, which can prime the complex of the virus with the ACE2 to facilitate its entry. And this is the essential protein to prime the viral ACE complex. Myocardium has cathepsin B and cathepsin L using the endocytosis pathway for the entry of this virus into the myocardium. That is probably one of the reasons why the heart is, though it involved, but not as worst as the pulmonary function, because in the pulmonary, they have TMPRSS making direct facility or entry of the virus into the lung parenchyma. In post-COVID period, the admission with ACS has increased. And it is probably is increase is a normal as a pre-COVID time. And none of these study has shown that there is a definite increment of ACS in a recovered COVID patients. There was incidence higher at the peak time, but those cases which is recovered show the same pattern. Thank you. And thank you once again to Dr. Brajesh and his team for organizing this conference. Most welcome for the questions.
Thank you so much. Now, before we proceed any further, we have two moderators here whom I have not formally introduced yet, and then I will leave the forum with them. So one is our guest from India, Dr. Chavi Mehra. Dr. Chavi Mehra is a senior physician, internal medicine. She has been a COVID warrior. She is quality head. She has founded some great clinics in Bangalore, and she is very active academician. So welcome, Dr. Chavi, all the way, sparing your time. Thank you so much. Our second moderator is Dr. Selvin George. He's my next door friend in the hospital. He's a wonderful, wonderful physician. Both of you have been COVID warriors, so that is why I specifically chose your session as where we have two talks on COVID. So Dr. Selvin is an internal medicine and head of medicine in our hospital. So both of you are very welcome. We have now I leave the forum with you two moderators, and our finishing line is for this session is 8:05. So after all the lectures are done, you can moderate the discussion among yourselves. With the speakers, and all the speakers are also kind of panelists. So thank you, welcome, and take on from here.
So welcome to everyone. Just want to introduce myself, Dr. Selvin George, working with Medcare Hospital, and I'm with the internal medicine department. So having some experience managing COVID patients, so I think this is a very useful session for most of us internal medicine doctors. So we not only see a lot of pulmonary complications, but our most feared is the cardiac complications that we face in COVID, and where most of the time, there is, although for the respiratory patients, we do get to use the ventilator and sustain their life. But when the heart is involved, it's really a very scary situation for all of us. And for our next talk, we have Dr. Vijay Sebastian, who is going to tell us about the hypertension management and its challenges. I think Dr. Sebastian needs no formal introduction. He's known to almost every doctor here in UAE. He has a lot of experience working in many hospitals, and currently he is heading the Department of Cardiology in Prime Hospital. And we all have listened to many talks of him since the past many years that we have been here. So it's going to be a wonderful talk. And I will leave the floor to Dr. Vijay Sebastian for his wonderful talk on hypertension management challenges.
Good evening, everyone. I am very grateful to Dr. Brajesh Mittal and the organizers for inviting me to make a presentation on hypertension, the challenges galore. The current views about hypertension is the most common chronic condition dealt by the primary care physicians. And 1/3 of the adult population globally have hypertension. Many of them remain unaware, undiagnosed, untreated, and when treated, very poorly controlled. Most of them have associated risk factors like diabetes, type 2 diabetes, dyslipidemia, obesity, smoking, and a family history of premature cardiovascular death. And it is a major cause for morbidity and mortality globally, and it is a silent killer. And in spite of several international guidelines, control of blood pressure remains as a major challenge in clinical practice. This is a very old one, it's several years old, and it's called rule of half for hypertension. And what happens is, of the all the hypertension, only 50% get diagnosed, and only 50% of the diagnosed get treated, and only 50% of the treated get controlled. So in short, it was considered that 12% of the hypertensives are adequately controlled. And in 1997, several years ago, after the rule of half is defined, the control of blood pressure globally is not very good, and the highest being in the United States. And National Nutritional and NIHANS study recently shown that hypertension among adults was 45.4. This is US data, higher in men than women. And awareness is about 69.9, and taking medication about 87% of the 69. And the blood pressure control is about 64% of the people who are getting treatment. And this is for USA. And other areas, blood pressure control is absolutely unsatisfactory. And we are not short of guidelines. We have guidelines for several years that is being amended, and we have the new guidelines. And still the blood pressure awareness, treatment, and control remains very poorly in most parts of the world. And what are the challenges? And to understand the challenges, I think we have to look at the basic practice, how we investigate and treat hypertension. And the first stage is confirming the diagnosis. Second stage is evaluate, and our purpose of evaluation is to exclude secondary causes, assess target organ damage, assess associated risk factors, and then the total risk assessment. And then it's very important, the patient education. This is not, the physicians and the patients are not really fully educated about the need for various lifestyle changes and medication. And finally, the treatment part, the lifestyle changes is to be really emphasized, drug treatment and the choice of drug and combination therapy, and managing the patients with resistant hypertension. And confirming the diagnosis, as you know, the office blood pressure recording, we have always come with white coat hypertension, which is an issue, masked hypertension, and both are not to be considered innocent. They have strong impact on prognosis and long-term cardiovascular risk. And home recording is a better correlation with CV outcome, and home blood pressure measurement improves awareness, compliance, and adherence. It could be a double-edged weapon, and sometimes patients panic and they even overdose. Ambulatory blood pressure has a better correlation with the future CV events, and nocturnal BP elevation correlates with the worst prognosis. And another major challenge is excluding secondary causes. And as you know, only 8% of the hypertensive population may have an identifiable cause of hypertension, and these are renal, endocrine, cortical aorta, drug-induced, and I want to emphasize on sleep apnea. And sleep apnea is now more and more aware or identified as a secondary cause for hypertension, and it can be corrected and treated. And the physicians are generally not looking much at secondary causes. It is very rewarding when you find a case where you can fully treat them. Risk assessment is very important to make a total risk assessment for every patient, because hypertension is not a disease of the left arm, but we always look at hypertension as hypertension. It's only a tip of the iceberg, and underneath you have dyslipidemia, smoking, advanced stage, male gender obesity, and diabetes, And so patient hypertension is in just the blood pressure alone. treatment of hypertension, we have non-pharmacological treatment and pharmacological treatment. And lifestyle changes before you start any drug. It's very, very important that every patient with hypertension should start with lifestyle changes. And here you have to really talk about losing weight, control of salt, exercise, and also relaxation techniques. And physicians often fail to educate about the role of lifestyle changes, and the patient do not practice lifestyle changes. These are very, very big challenges in the practice. The new guidelines on choice of drug, it is the level of the blood pressure that matters, however you bring it down. Even if you sing a song to the patient and bring the blood pressure down, it is good, And choose the drugs according to the patient characteristic is very important. And also remember compelling indications and preferred drugs. And it's always a question of single drug or combination drug. This is really a challenge in the practice. And so what percentage of the patients with hypertension control with one drug? It's only about 33%. And when you add the second drug, you get another 33%. And when you add the third drug and lifestyle changes, you can get additional 37%. So what happens now is most of the physicians are hanging on to monotherapy. And I think this practice has to change. There is a need for physicians to understand that very often many of the patients need more than one drug. And this is why, because if you look at the various drugs, there's only some. And combination treatment is for quite some time. Anglo-Scandinavian trial has got 90% of the patients need a treatment to achieve the targets, and they had fewer cardiovascular events when they control with the unit drugs. And also we go back into J&C, say most of the patients require 2 or more antihypertensive drugs to achieve the goal. And also they went on to say that if the target you want to achieve is 20 systolic or 10 diastolic above the goal, it's better to start with 2 drugs. And this is, again, if you look at various trials, you say receiving more than 2 or more drugs, and if you let the Veterans Administrator, is almost 100%. So physicians' inertia, physician delay initiating drugs in many patients. This is also one big challenge, because it's very comforting to the patient to say that, look here, you try lifestyle changes. I'm not going to start any drug now. I think this is very wrong. I think it is very important to initiate the treatment early. And they often start with single drug and delay on adding on a drug. And combination therapy is often not used as the first line among many of the physicians. And when BP is not controlled with the 3 or more drugs, patients should be re-evaluated. And again, just a review of resistant hypertension. By definition, when the blood pressure levels are repeatedly above 140/90, with the 3 antihypertensive drugs, including a diuretic at the optimal dose, and check compliance, that's very important. Ambulatory blood pressure recording may help. And strict control risk factors and precipitating factors. And again, you have to re-evaluate them for secondary causes and add aldosterone. So resistant hypertension also, in our daily practice, many physicians are not really controlling it. And sometimes catheter-based renal ablation, renervation is needed. It yields results in many patients, but not all. And however, long-term results are still awaited. And the guidelines, though clearly accept the encouraging results, suggest look for confirmation before considering widespread use or abuse. Restrict application technique to centers fully equipped with a trained operation. And centers should be capable of managing eventful, unexpected consequences. And the major challenges, I just want to conclude, my colleagues, there are patient-centered issues like lack of awareness, associated risk factors, non-compliance to lifestyle changes and medication, lack of follow-up. And there is also physician-centered issues or challenges, not well informed and updated about the new guidelines, failure to diagnose and educate the patient, not excluding secondary causes, failure to advise on importance of lifestyle changes, and failure to initiate drug and follow-up. This is a real physician's inertia, and lack of knowledge of antihypertensive medication and their choice. And patient education is very, very important. So I want to conclude my presentation with achieving target is often difficult and challenging. And Samuel Beckett said, ever tried, ever failed, no matter, try again and fail again. Thank you very much for your kind attention.
And physicians who have been attending, it's going to be very important to understand how important the patient communication is. Probably, I think it's the most difficult task in our practice, to spend more time trying to talk to patients. It's sometimes easier to just prescribe medications and let the patient be on the way. I just want to, probably many doctors would have also faced the same situation. Recently, a lot of patients have been coming to me where they felt that their blood pressure was on the higher side when they went for their vaccination campaign. And repeatedly when they check, their blood pressures are hovering on the borderline. Many of them are kind of reluctant to really be taking the medications. How would you, Dr. Sebastian, advise us physicians to tackle the situation from your own words?
I'm sorry to
Hello.
intervene. I'm sorry to intervene. May I request moderators to please keep the question, answer, and discussion at the end of the sessions. So let us go with the flow of the. I'm so sorry, Dr. Selvin, but we'll have the
Okay,
same
no
question
problem.
at the end of the session. So now the time for the next lecture, and Dr. Chavi, you can introduce and start the next lecture.
Hello, everyone, and I'm Dr. Chavi Mehra, as I was earlier introduced. I'm a physician, internal medicine in Bangalore, and I have been practicing primary care medicine for the last 25 years. It's my pleasure to introduce Dr. Brajesh Mittal as our next speaker. He's the Deputy Medical Director, a consultant interventional cardiologist, head of cardiology, Medcare Hospital in Dubai. And he also is the chairman of Shake. So he doesn't need any introduction. And he's coming up with a very interesting topic that we all are waiting to hear, and which is heart in overdrive, set the pace right. So welcoming Dr. Brajesh Mittal to go on with this presentation.
Respected chairpersons and fellow colleagues, good evening. The title of my talk is Heart in Overdrive, Set the Pace Right. So first of all, we need to understand what does overdrive means. Is it a technical term or is it just a hearsay term? So we need to understand the concept of sympathetic overdrive. More than 50% of the global population is young to middle-aged. And in this population, sympathetic overdrive is the main cause of hypertension, and more than 50% of patients with hypertension have an elevated heart rate in this age group, which reflect on the causative sympathetic overdrive. We know that there is a sympathetic nervous system and there are ganglia, and they release the neurotransmitters, norepinephrine and epinephrine. Chronic sympathetic activation or sympathetic overdrive has been implicated in the development of metabolic syndrome and other cardiovascular risk factors. It is associated with increased heart rate and multiple cardiovascular risk factors. In a complex interplay, the sympathetic overactivity leads to more hypertension, more insulin resistance, obesity, and they are all interrelated with each other. And increased heart rate is ultimately cause of more heart failure, sudden deaths, and coronary events. Diabetes can activate the sympathetic nervous system by more insulin resistance, more norepinephrine release, producing more ventricular arrhythmias, more plasma renin activity, more angiotensin II, like that. So beta 1 adrenergic stimulation induced cardiac and coronary artery damage leading to atheromas, and BP plus non-dipping at night. This sympathetic overdrive also leads to multiple responses that contribute to heart failure or sudden death. Acute mental stress. This is also associated with high release of corticotropin releasing hormones and cortisol's pro-inflammatory cytokines, as well as higher sympathetic nervous system activation, contributing to increased cardiovascular risk. Similarly, central obesity also, by producing more of leptin and by causing more endothelial inflammatory response and damage, leads to obviously more norepinephrine release and more sympathetic nervous system activation. And smoking, another risk factor for cardiovascular disease, acts through stimulation of sympathetic ganglia, higher release of norepinephrine, and increase in peripheral resistance, increase in heart rate and blood pressure. How are they linked to blood pressure? How is sympathetic overdrive linked to blood pressure? Age-old definition we might have read in physiology 30 years, 20 years, 10 years back in your career. So BP is equal to cardiac output and peripheral vascular resistance. Cardiac output is equal to heart rate into stroke volume. And sympathetic overdrive increases heart rate, it increases peripheral vascular resistance, and thereby leads to higher blood pressure. And that is why there is a role of beta blocker when the hypertension is associated with sympathetic overdrive. In this particular table, you would see that if you take a threshold of systolic and diastolic pressure 130 by 80 as the hypertension definition by 2017 guidelines of ACC, you recruit a large number of young and middle-aged people, and who would ultimately have a pathophysiological cause of hypertension at sympathetic overdrive, and they would need preferentially the beta blocker therapy. So underlying causes of hypertension differ between the young and old by the Framingham Heart Study. The predictors of diastolic hypertension plus minus systolic hypertension: younger age, male sex, high BMI at baseline, and increasing BMI during follow-up. In this group, main mechanism of diastolic hypertension and sympathetic overdrive is raised peripheral resistance, and sympathetic overdrive is the main cause of hypertension in young or middle-aged patients. Increased heart rate is individually and independently associated with increased cardiovascular events. So in this particular graph, the portion B is high heart rate with a controlled blood pressure, and they still have a cumulative higher primary event rate. It was more than the people who have a low heart rate and uncontrolled blood pressure. So this is a misnomer. So heart rate control was equally or even more important than just the control of blood pressure. The people who have both very well controlled blood pressure and heart rate were the best. So our target when we control the hypertension in such a population is not just the blood pressure, but also the heart rate, because it was shown that all-cause mortality, CHD and CVD mortality was consistently higher in those who were having higher heart rates. Increased heart rate increases the risk of mortality in young men, and all-cause mortality in people with more than 100 heart rate was much higher as compared to those who had heart rate between 60 and 80. The 80 to 100 group was actually not also quite good. They were also at a risk. So anybody above 80, we should think of considering giving the medication to reduce the heart rate besides blood pressure. So there are many strategies to reduce heart rate, but here we are talking of sympathetic overdrive, the heart rate related to sympathetic overdrive. So in that sense, only beta blockers are the medications which will control heart rate via actions of on sympathetic overdrive. The verapamil and diltiazem like CCBs are not effective for sympathetic overdrive. Similarly, medications like ivabradine, they do reduce heart rate, but they do not affect the sympathetic overdrive. So we have to select the medications accordingly. Beta blockers cause marked reduction in cardiac sympathetic nervous system, and they also have effect on peripheral sympathetic nervous system. Some medications actually increase the like short-acting calcium channel blockers. They increase the effect on peripheral as well as the cardiac sympathetic nervous system, and many others have no effect at all. So beta blockers are the mainstay of therapy in hypertension associated with sympathetic overdrive. It's a large group. We know about it. There are many agents, and not all beta blockers are the same. So we have, once we decide that patient need beta blocker, we also need to know which beta blocker. There are three types of beta receptors: beta 1, beta 2, and beta 3. Heart muscle, bronchial and vascular smooth muscle, and beta 3 endothelium and NO-mediated vasodilation. And they have a range of indications, including hypertension, heart failure, tachyarrhythmias, anxiety states, ischemic heart disease, hyperadrenergic drive, which is also a part of the list. They are existing for many decades, and they have been changing indications, sometimes in favor and sometimes against, but they are still a very, very useful group of medications. We have 3 generations of beta blockers now. So first generation, we probably don't use unless in some specific circumstances. In the second generation agent, we select the one with the highest beta 1 selectivity. The first generation were non-selective beta blockers. And in the third generation, we select an agent, something which is still quite selective with vasodilatory properties. So in hypertension, you may argue for and against beta blocker. So in uncomplicated hypertension, you may avoid using beta blocker, or you may use other drugs preferentially. But in any hypertensive patient with CAD, with arrhythmias, and if you see the evidence of increased sympathetic activity besides congestive heart failure, all these become candidates for the use of beta blockers. The early morning BP surge leads to higher myocardial infarction and higher stroke rate. So we have to have a medication which takes care of this particular part of the problem. So we have to select an agent which has a higher peak to trough ratio. And bisoprolol is one of those agents as compared to atenolol. So atenolol given once daily does not provide a long-lasting blood pressure effect. So we need to be careful when we select which medications can provide the best effect and most utility value in terms of not only the control of blood pressure, but also the reduction in the overall cardiovascular outcomes. Nebivolol is another such medication which works for over 24 hours, and its TYP ratio is still quite high, 89%, and it is also beta 1 selective. So why beta 1 selectivity is important in the treatment of hypertension? Because beta 1 receptors are present in the myocardium, and they increase the contractility and heart rate. They increase myocardial necrosis and apoptosis. Besides, they are also present in kidneys and lead to more renin release. So beta blockers may be particularly beneficial in hypertensive patients with all such conditions where there is a chance of higher sympathetic overdrive, like central obesity, diabetes, and insulin resistance. They reduce mortality in the overweight, obese, high-risk hypertensive patients as per the UKPDS trial, and there was 23% reduction in death from any cause in patients receiving a beta blocker in such group. Their beta 1 selectivity is important to understand, and we should select the agent which have highest beta 1 selectivity, like bisoprolol, like metoprolol, like nebivolol. And we should avoid using the agents which have intrinsic sympathetic mimetic activity because they can increase the sympathetic action. Based on their utility value, the European guidelines as well as other guidelines indicated and defined the role of use of beta blockers in hypertensive patients. So heart rate, if resting value is more than 80 per minute, it is considered to be a cardiovascular risk factor, and heart rate should also be recorded at the time of BP measurements because resting heart rate is an independent predictor of cardiovascular morbid or fatal events. So we should not forget this concept. Similarly, in the NICE guidelines, they say that when there is evidence of increased sympathetic drive in younger people, we need to use beta blockers preferentially. The guidelines clearly recommend that beta blockers should be considered for initial therapy of hypertension in younger people. And in the Canadian guidelines, beta blocker is one of the 5 suggestible agents, especially in people less than 60 years of age. And we need to know the beta 1 selectivity relatively. So the highest beta 1 selectivity lies with the agents bisoprolol and nebivolol. Bisoprolol has a 19.6-fold higher affinity for the beta 1 receptors than the beta 2 receptors. The efficacy of bisoprolol versus nebivolol in the treatment of hypertension was shown to be, and Nebis trial was shown to be very sustained action and very similar action in terms of control of the blood pressure, both systolic as well as diastolic. So, friends, ladies and gentlemen, the take-home points in conclusion of this presentation is that sympathetic overdrive is associated with the development of multiple cardiovascular risk factors and is the main cause of hypertension in young and middle-aged men. Beta blockade helps to prevent the adverse effects of sympathetic overdrive and could protect the heart at every stage of the cardiovascular continuum. Highly selective beta blockers with once daily dosing are treatment of choice in young hypertensive patients with additional risk factors for sympathetic overdrive. For example, smokers, obese, diabetics, and people with higher levels of stress. Thank you very much for your kind attention.
Thank you, Dr. Brajesh. That was an amazing lecture on the beta selectivity for primary care practitioners to make sure that we are more aware of the long action and the beta selectivity to reduce the sympathetic overdrive. Thank you very much. And now invite Dr. Ghassan to introduce our next speaker.
Thank you, Dr. Mittal, for your wonderful presentation. Next, we have Dr. Ghassan. He's also a very close colleague of mine who works in Medcare Hospital. And his special interest is in interventional cardiology as well as diagnosis and management of all cardiovascular disease. I should also say that he was very much involved in the management of patients who were suffering from COVID. And he was also helping our team to manage many of our COVID patients. And we often had to call him to manage those with cardiac involvement. And we used to always see him walking around in his PPE in the hospital. So he's a very dear friend of ours who really, we relied on him so much during the COVID pandemic. So he's going to talk about the topic sufferings beyond the sufferers. So it's going to be an interesting talk, and let's see who are the sufferers and what were the sufferings that they went through. And over to Dr. Ghassan. The floor is yours. Thank you.
Good evening, everyone. Thank you for joining us on this lovely meeting. Well, today I chose this topic because amid all the science, I think that we have to take a step back and look at the people that are actually practicing that science, the mental and the physical effect on them, and also a bit on the non-COVID patients or general population. Basically, the definition of burnout is a syndrome of emotional exhaustion, depersonalization, and a sense of low personal accomplishment that leads to decreased effectiveness at work. It differs from from depression as because it's mainly related to work issue, but it can still spill onto your own life. Problem is big, and in an article published in the year 2000 in the American Psychology Journal, a review of the whole literature dealing with mental health and doctors showed around 130 to 140,000 articles relating to depression and anxiety, whereas happiness and joy reporting articles were by a mere 4,000. In the COVID era, this has not changed. And the physicians' burnout remain at critical 42% overall level, with the critical care holding number one nowadays. Women are hit hard. 21% of women who report current burnout have never had anything before the pandemic. And the factors cited include lack of adequate personal protective equipment, grief from losing patients, watching families suffer, long hours, and difficult working conditions. I personally must add to that the lockdown effect on the families and on the working people, and the financial constraints that were mandated by the pandemic itself. So how bad is it? 1% of physicians have attempted suicide, and 50% of physicians have thoughts of suicide. How do we quantify the problem? Basically, HR used the mass/burnout inventory scales for physicians. It relies on 5 big chapters, actually. So emotional exhaustion when you feel emotionally drained, depersonalization when you lose empathy towards your patients, personal accomplishment is when you just don't feel as if you're doing the correct thing anymore. Cynicism is losing the feeling towards the profession and the workplace. So basically, you lose the happiness or the edge of being a physician, and you lose the joy of coming into work. And professional efficacy is when you just don't feel as if you're making a difference, whether at your work, with your workplace, or with your patients. What does that lead to? We know that hypothetically, burnout leads to vital exhaustion, hence sleep disturbances, immunity issue, coagulation is an issue, hypothalamic pituitary adrenal axis degeneration, leading to an increase in inflammatory markers and supposedly leading to cardiovascular diseases. This has been thoroughly addressed in an article published in 2008 in the Journal of the American College of Cardiology. I relate this article a lot to what we are currently living, and the instance whereby that article has divided the stresses into acute and chronic stresses. So the acute stresses being disasters, and here we will see earthquake disasters that doesn't fall short actually from the pandemic and the blockage of the pandemic that has been inflicted upon us, and experimental stress physiology studies whereby you subject your subject to an increased mental effort. And I think most of doctors, while we not knowing what to do with COVID patients, we have very sick patients, and we don't have algorithm or studies reflecting on appropriate treatment. Basically, that subjects us to also the mental stress, the chronic stresses being job stress, marital unhappiness, and burden of caregiving. Those, we have to emphasize that those stressors were mostly triggers rather than a clear cause of the cardiovascular event. So basically, during the 1999 earthquake in Taiwan, researchers were able to gather 12 patients to whom at that time a heart rate monitor was attached for different reasons. And they saw an increase in the heart rate up to 160 beats per minute with sinus tachycardia that persisted up to an hour after the earthquake. More interesting is that they noticed heart rate variability changes up to 24 hours or to the whole duration of the Holter monitor recording after the earthquake. And we know that heart rate variability kind of gives us an idea about neurocardiac modulation. So the activity of the sympathetic and the parasympathetic system working together. And whatever we saw was an increase in the sympathetic tone throughout the day that followed the earthquake. In January 1994, after the Los Angeles earthquake, we saw a sharp increase in cardiovascular, atherosclerotic cardiovascular disease-related mortality as as compared, to the years before. In Niigata in Japan in 2004 also, we saw a sharp increase in pulmonary embolisms and also an increase in the rates of pulmonary embolism with the aftershocks of the earthquake as compared to the years before. Now, in a similarly interesting article that was published in the Lancet in 1984, 16 patients whom had a positive nuclear stress test were subjected to mental exercises. And you see that on mental exercises, 75% of the patients manifested abnormal perfusion patterns, out of which 50% had neither ST segment depressions nor angina. So basically what this tells us is that we can induce ischemia while having a mental or a mental stressor can induce subclinical ischemia in patients with non-coronary artery disease. So this is an important message to all of your patients with coronary artery disease, and basically the doctors that have coronary artery disease to might stress very carefully. The chronic stressors are mostly related to epidemiological rather than pathophysiological studies. So this relates to job stress, marital discord, day-to-day microstressors, and perception of being treated unfairly. Hence, how does it relate to our time? So marital discord, day-to-day microstressors, for me, that might correlate very well with the lockdown. And perception of being treated unfairly is whatever changes that are happening in the workforce nowadays. So, an interesting article in 2007 was published about the siege of Leningrad in World War II. So basically, there have been an increase in hypertensive diagnoses whenever Leningrad was sieged. And 50 years later, they noticed that hypertension and starvation combined led to an increase in mortality from cardiovascular diseases as compared to other cities at that time that did not undergo any siege. Why am I putting this forward? Because we're seeing a lot of patients nowadays, with diagnoses of hypertension. And we're basically attributing that to the fact that everyone is being screened before vaccination. Now, I don't know if those patients are usually hypertensive and never tested themselves, or the stress is causing them hypertension. But if I have to relate to this study, I think that in 30, 40, 50 years, we will see the cardiovascular effect of this pandemic. So it's not only a short-term effect, that might also be a long-term effect. Shakeheart study showed the relation of chronic stressors and the incidence of MI in a sample of patients of 25,000 people from 52 countries. So basically, feeling irritable and having stressors at home and at work cause an increase of about 2.1 times the risk of developing a heart attack. Within the same line, the Whitehall study found a 2.15-fold increase in the risk of coronary heart disease in men. The multiple risk factors intervention trials found that chronic work stress and marital dissolution increased the risk of cardiovascular mortality in men who were followed for 9 years. And in a study published in 2020, performed in Stockholm, marital stress was associated with a 2.9-fold increase in recurrent events in women with prior coronary artery disease, whereby work stress did not predict any subsequent events in those women. So basically, guys, if your woman is telling you you're going to give her a heart attack, that's most probably true. And that also contrasts with the fact that men are more triggered by their work rather than by their home stressors. Now, how do you know where you are, and how do you quantify it to yourself? So basically, the classic stages of burnout are overcommitment, beginning exhaustion, increasing exhaustion, and feeling burnout. The moment we stepped into med school, I think we've stepped already beyond stage 1 and probably into stage 2. If we look to the diagram on the right, we see that every pattern of those can be quantified from 0 to 10, and we can draw our inner circles ourselves. So I suppose that the bigger circle there is, the more overwhelmed we will feel, the more worked out we will feel. But also, the more predominant your zone is on the lower side, so on the bottom half of the circle, the more subjected to burnout you might be. Now, what to do about it? In 2019, a study was published that showed that the probably only effective interventions are organization-directed workplace interventions that focus on the 4 T's, so teamwork, time, transitions, and technology. Whenever we as physicians perceive that we're working as a team, it decreases the stress, it decreases the workload. Whenever the time is well organized, so we're not staying over hours, and the management is actually pushing us to resting hours, the better that will be. We know that there have been a lot of policy transitions and in very new adaptations in the healthcare system. So the smoother those transitions, the better perceived well-being is, and definitely technology adds up to a very high level with electronic EMRs, PACS systems, so on and so forth. The individual level, emotion regulation, self-care workshop, and mindfulness meditations, along with stress management skills and communication skills training is what is required. I cannot stress more on mindfulness meditation plus or minus yoga. Those are techniques of mental relaxation that I use basically, or I teach my heart attack patients to utilize. And I think that in acute stressors, those mindfulness techniques work a lot. So I end with this slide. We end with how to build up resilience. So basically, at work, if you have good debriefing sessions, good teamwork and transitions, good work schedule timings, stress management training, self-care workshops, and communication skills training, all of this will reduce burnout to cause or to induce more resilience at work, and to hopefully we will make it safe out of this pandemic. Thank you.
Thank you very much, Dr. Hassan. It was a fabulous discussion.
Thank you.
I think this has been an eye-opener for all of us physicians here who listen to your talk. I think it's very important, and it's also important for us to understand that physician burnout is definitely a thing that happens, and many of us might ignore it. And I think an important key to combating physician burnout is teamwork, something to take home today message. I think I will hand over to Dr. Chavi, who can lead in some discussions.
Yes, there is a question for Dr. Mittal, and the question says, where beta blockers have been downgraded, should there be a third-line drug in all hypertensive? Dr. Mittal, this is a question for you.
Yes. So the answer is beta blockers are not downgraded. It was only one time in American College of Cardiology guidelines that they put the beta blockers out, and it was not out. It was like, if compelling indication. Now, what are the compelling indications? That is a huge list of compelling indications also. So we thought that beta blockers are out. They were not out. They were not supported as a first liner. So that was in the ACC guidelines, but in the ESC guidelines, they are still one of the medications, and similarly in the NICE guidelines, they are one of the medication, not below the other medication. They are one of the suggestible medications. So we should not get guided by the fact that they are no more the antihypertensive medications. This is the crisp, simple answer for the question.
Yes, and I felt that your discussion about diastolic blood pressure in younger individuals and obese and male. And I think beta blockers have a great role in that. I think that was very good. So I mean,
Yeah.
yeah. Dr. Mishra, I have a question for you regarding your the post-COVID phase of cardiac disease. Congestive heart failure is something that has been brought to focus of physicians. What do you have to say about, except not acute coronary syndrome, but congestive heart failure? What do you have to say about that?
Yes, there are definitely some publication also there, and we have also seen in our cases that some cases, especially those who have a pre-COVID conditions, comorbid condition, diabetic or ischemic heart disease, or previously congestive cardiac failure, they have suffered worst. They end up in congestive cardiac failure. Their anti-pro-BNP were very high, and they required medication also to treat. Those who were young and healthy, they invariably did not go for congestive cardiac failure. It was old group of the patient, they have more suffering.
Thank you very much.
Yeah.
Thank you.
So I have a question. Yeah.
Yes.
Okay.
I just like to add one important point about Dr. Ghassan's talk is that in Abu Dhabi, the Department of Health, Government of Abu Dhabi, they have introduced 10 module mandatory to all physicians, especially those who are dealing with critical care patients and ICU patients, to complete in a time-bound period by end of this March. And in those 10 modules, 2 modules dedicated for the conditions what he just mentioned for physicians. And all of we have completed there, and there is a many of lectures about burnout, about physicians' health, about this condition. I wish I can forward this to our Dubai friends, this module.
Good. Yeah. So
yes, Doctor.
I have a question and also an experience to share that in last 1 year since the COVID started, we have had encountered certain patients who suffered COVID infection and were otherwise quite risk-free, and in a couple of months or in a couple of weeks, they presented with a thrombotic coronary occlusion. So there does seem to be some association between the acute onset of new myocardial infarction in relatively very normal, healthy young men after the COVID infection. So any further comments, Dr. Mishra, from your side?
Yes, yeah. Actually, we haven't, or we have also seen, but these are few isolated cases in which a patient has unexpectedly developed acute ischemic or acute myocardial infarction, which were not expected. So we definitely cannot say that is it precipitated because of the COVID or it is just by chance. The studies I have screened many of the studies, but no one has come out that there is a definite rebound. There is a definite increase in myocardial infarction post-COVID, but none of them is categorically saying that the COVID cases has got high incidence. They say there is a rebound and there is some incidence in post-COVID cases. But as I said, interestingly, that the myocardium does not have TMPR SS2, which is necessary to prime this complex of COVID virus with the ACE2 inhibitor. And that is probably one of the things why the myocardium is not so aggressively damaged. Majority of the cases, once they recovered, all myocarditis, pericarditis, they are improving. I haven't seen a chronic case end up with cardiomyopathy. They're all improving by 3 months to 6 months.
Okay.
Good to know that.
Yeah. Any quick comments from Dr. Chavi and Dr. Selvin before we finish off? And anything more you want to add up in the session?
One comment on the COVID, because I have encountered very closely. My wife, in fact, had COVID, very severe infection. She was in WellCare Hospital, Dubai for 7 days on ventilator in a very critical stage. And we have a long, like all the treatment, including the plasma therapy, and then she totally recovered. Now she's fine, totally out of danger.
Okay. Wonderful.
So
Great.
we have
Thank you.
seen very critical cases altogether, many
Wow.
including my family.
Wow. Wow.
Wow.
Very pertinent topics. I think this session
Yes.
has been great, Dr. Mittal. I think for physicians, Dr. Sebastian was fabulous with his hypertensive talk. And you also are keeping us abreast of the sympathetic overdrive, and not to forget that, and we will remember that. Dr. Gaston was fabulous with his talk on our exhaustion and our burning, and we can't deny that as physicians. We all have to work with ourselves at every stage of our growth and career. So I really want to thank everybody here for their wonderful academic sessions, and with that, I think we'll conclude our session today.
Thank you so much.
Thank
you.
So, thank you, moderators and fellow speakers. Thank you so much.
Thank you.
Good evening. So I will introduce the moderators of the next session, and then the moderators will take it forward to introduce one by one the speakers of the next session. So we are slightly delayed, only 3 minutes, and I'm very much calculated the time, and we'll finish in time because I have all the data, how many minutes each recording is there. So we'll still have some time for discussion. And I will also welcome Dr. Yasmin, who is joining us from Kingdom of Saudi Arabia. She has been to our scale meeting before. Now, at this point, is Dr. Mirullah here? Dr. Mirullah, Dr. Rami, and Dr. Ravi Shekhar. Yes, Dr. Rami, good evening.
Good evening,
Dr. Dr. Rami has a unique profile. He is a cardiologist and turned into completely, interventional radiology, I would say, kind of non-invasive MRI, cardiac MRI, and cardiac CT. So he is one of the best persons for us to guide us in many difficult situations. I'm happy that he is one of the moderators here. We also have Dr. Mridula Dhakar as one of the moderators and chairpersons, our old colleague, friend from many years in Dubai. She is a practicing interventional cardiologist. She is the second one who will lead the moderating session, this particular session. So with this, I hand over the reins of the next session to the moderators. I don't see the other two moderators here at the moment. So the floor is all yours. You run the session, and please go forward. Thank you.
Thank you, Dr.
Will organizers, yes, will organizers just do their initial video presentation and take it forward.
So, good evening, everyone. Thank you for being here.
Good
Dr.
evening.
Yasmin, Dr. Dakad, Dr. Misra.
Good evening.
It's a pleasure to see you again, Dr. Yasmin. I know we have a very similar profile, so
Exactly.
we basically graduated from Paris from the same hospital doing cardiac imaging and cardiology, and you continued after that in the Royal Brompton in London for subspecialty, and after that you're practicing mostly advanced cardiac imaging and grown-up congenital heart disease. You're working now in Riyadh in KSA, and it's always a pleasure to really hear you speak, and I'm looking forward to hear you speak about advanced cardiac imaging in coronary artery disease patients. Please, the floor is yours.
Hello, everyone. I'm Dr. Yasmin Hanfi, consultant cardiologist, specialized in advanced cardiac imaging in Saudi Arabia, in Riyadh, and I will be happy to present with you the lecture about imaging in coronary artery disease. And I will start my presentation with this old table. Shows the clinical pretest probability of coronary artery disease has been been guided in the guidelines, in the old guidelines, and this is pretest probability of coronary artery disease has been guided with the patient age and the presentation of angina, whether it's typical or non-typical angina. But actually, this table lately in the latest guideline has been changed, and instead of the pretest clinical probability, the clinical likelihood of coronary artery disease has been replaced. In addition to that, they have added another modifier to the pretest probability, including patient age, risk factors, and dyspnea included, with also the coronary calcium score. And coronary calcium score has been added. And just I want to mention something that if coronary calcium score is 0, it is associated with low prevalence of obstructive coronary artery disease with below than 5%, and the risk death or non-fatal MI by 1%. However, we have to note that the absence of coronary calcium scoring, or if there is a calcium score of 0, does not exclude coronary stenosis caused by non-calcified atherosclerotic lesion, and the presence of calcium is also a weak predictor of obstructive coronary artery disease. But this is an addition to the latest guideline to the clinical likelihood of coronary artery disease. So if we look at this schedule, the determinant of the clinical likelihood of obstructive coronary artery disease, according to the latest guideline in November 2019. So there is a high likelihood or decreased likelihood, and the parameter in addition is the risk factor, the inherited risk factor, dyslipidemia, diabetes, hypertension, and family history. In addition to that, resting ECG with Q wave or ST segment T wave in changes, and LV dysfunction with regionality, abnormal exercise ECG, and this is an interesting point, and a coronary calcium score. And the absence of this is the decreased likelihood, and the 0 calcium score is another category. So first stratify the clinical likelihood, and then you will go to the next step. If the clinical likelihood is more than 15, then you go for non-invasive test. But actually, what was interesting in the latest guideline 2019, that if we have a patient presented, we will start by doing coronary CTA. And that probably will come to a surprise to most of the physicians that exercise stress ECG is not anymore on the list. So with a patient who has low likelihood, he presented with angina that is very atypical, and he has a very low pretest probability, you start doing triaging this patient by doing coronary CTA. And accordingly, we will categorize this patient whether he has obstructive or severe coronary artery disease or non-obstructive coronary artery disease. And when you have a patient, and this patient has a high likelihood of coronary artery disease, you don't do coronary CTA. You go for non-invasive testing, the functional testing. You don't do coronary CTA for patient with high likelihood, because that will make a patient having an artifact probably, and actually you need a functional test to assess whether you need to be guided to a revascularization or not. And if we look at the coronary CTA. Coronary CTA is superior. Shakeheart trial has been shown its superiority. PROMISE trials, Shakeheart trials, the Shakeheart trial especially showed that the patient has beneficial of being not missed or underdiagnosed with coronary artery disease. And if I go to the functional test is a rule to power in for revascularization or not. So not to establish the disease, but also but for the patient who are already high likelihood, and we need to know that we need to revascularize or not. And interestingly, there is a power of those tests, and we got to learn which power to use for those patients, so we don't miss those patients. So if we take exercise ECG, stress echo, SPECT and PET, and stress MRI, the highest sensitivity among all those is the latest one, the PET and stress MRI, with 90% sensitivity to detect a significantly coronary artery disease, more than 50%, and significantly functionally significant with FFR more than 0.8. So stress MRI and PET CT, 89% for functionally significant coronary artery disease, 90% for anatomically significant artery disease, in comparison to exercise ECG, which is only 58% sensitive. So exercise ECG has inferior diagnostic accuracy, but we know that it has a good prognostic factor, including the blood pressure response and arrhythmia response. This is again a comparison of different functional modality in detecting clinical likelihood of significantly coronary artery disease. Okay, so this is one of the factors that shows you that stress MRI PET is really potent test to detect that. And I want also to add additional trial that shows that stress MRI comparing to SPECT, our traditional test, is also superior to detect as left main disease or left main equivalent the coronary artery disease if we compare it. So this trial is a large randomized trial, hypothesized that MRI is superior to SPECT in detecting left main disease or left main equivalent, which is defined by 70% stenosis of proximal LAD or 70% of proximal left side and more than 50% of left main disease. 752 patients were included. They underwent cardiac MRI, stress, and SPECT. And just a brief presentation about adenosine stress MRI. We take stress perfusion images during stress after injecting adenosine, and we take also wrist perfusion images, and then also we assess the regionality through multi-slice imaging, long axis and short axis. And this is one of the examples of positive stress MRI with video is working, yeah. It shows that hypointensity area, if you can tell, in the anterior anteroceptor, in anterior anteroceptor wall, and also in the lateral wall. This is how we defined ischemia by stress MRI. And for those 750 patients, we found that the ability of stress MRI of detecting left main disease is 81% compared to SPECT with 59%. So this is a really significant insensitivity to detect left main disease or left main equivalent comparing stress MRI and SPECT. So also an additional features of stress MRI to diagnose microvascular dysfunction, which is most common presentation in female with chest pain. And I will go to the next part, an important part of my presentation, which is the ischemia trial. What if we establish a diagnosis of coronary artery disease? And then we found the patient has coronary artery disease of 50% and he is stable. Of course, we need to get the answer evidence-based. And ischemia trial took those patients with moderate ischemia, more than 10% by all different modality with a stress exercise ECG, stress MRI, echocardiography, and SPECT. And just to answer this indication for revascularization, which is class 1B the larger ischemia, more than 10% of the left ventricular and abnormal FFR, but the patient is stable and have silent ischemia. Otherwise, for left main disease, more than 50% is class 1 level of evidence A to go with for revascularization. But for those patients with only ischemia and abnormal invasive FFR, ischemia trial came to answer this. They took 5,000 patient participants in 37 different countries with a 4 years follow-up. They divided those patients after performing CCTA to exclude left main disease, of course, and then they divided into invasive strategy and conservative strategy. The follow-up was 3.5 years. Primary endpoint was composite of cardiovascular death, myocardial infarction, and resuscitated cardiac arrest, hospitalization for unstable angina or heart failure. And in the invasive strategy, when there is an anatomically suitable for revascularization, they went CABG or PCI. If the stenosis is below 50%, FFR were there to assess the significant below 0.8, they went, of course, for PCI or CABG. The conservative strategy group, optimal medical therapy, were obtained, but those patients went for cath when they have refractory angina, and they have, despite medical therapy, of course, and when they were not adherent to optimal medical therapy, they also went for invasive. And the result of ischemia trial showed that 96% of those patients went to angiography, 79% has underwent revascularization, and in the conservative strategy, 26 of the patients underwent angiography, and 21% underwent revascularization. Again, the characteristic of the patient, they were stable, left ejection fraction was 60%. They have frequent angina, 44% in the invasive and conservative, equally 44% of frequency of angina. And the result of the trial in the primary composite and the endpoint compared conservative and invasive strategy were almost no difference, no significant difference in the primary endpoint. And we noticed also in ischemia trial that the patient in invasive group, they have fewer angina symptoms than in the conservative strategy group. As it shows here in the paragraph, the quality of life has improved in favor to invasive strategy. So what our conclusion from ischemia trial, that if there is a strict adherence to unstable coronary artery disease in patients who fit the ischemia trial, stable, normal ejection fraction, and they don't have a significant angina, they can be treated initially as in conservative therapy. And when there is a favor of invasive, when the patient has frequent angina and needed symptom relief, they can go for invasive treatment. So the take-home message, ischemia trial confirmed that dengue patient, mostly men with stable symptoms, normal ejection fraction, normal or impaired renal function, with evidence of moderate to severe ischemia on stress testing could be risk stratified with coronary CTA to exclude a significant unprotected left main, and they managed with optimal medical therapy alone. Invasive coronary angiography could be reserved for those who have frequent angina despite medical therapy. In ischemia trial, there was no evidence of interaction with the degree of ischemia on the outcome. Thank you for your attention, and I'm happy to hear your question.
Thank you, Dr. Yasmin, for this elegant lecture. We'll go to the question and answers at the end of the session.
Thank you very much, Dr. Rami.
Dr. Mittal is here. Dr. Mittal? Dr. Mittal? I can't see Dr. Mittal. Dr. Mittal is here or no? Okay. So I don't see Dr. Mittal here. Maybe some technical issue with her. So I take this pleasure to invite Dr. Lochen to give the next talk. Dr. Lochen is a very senior cardiologist in Dubai, more than 20 years. And he's a consultant interventional cardiologist in Al-Zahra at the moment. So we want to hear from his prolific talk, hemodynamic and electrical compromise, Achilles heel of acute MI management.
I'm here, Dr. Mittal. I'm sorry, there was technical glitch
So please, you can introduce Dr. Luchan. I took your task
Sure.
here.
Oh,
Now,
well, you
please,
have already introduced. Thank you, first
no,
of all,
please,
Dr.
once again,
Brajesh Mittal, for arranging such a beautiful
my
symposium once
pleasure.
again. And who doesn't know Dr. Lochin? He's been the oldest. He's a stalwart cardiologist, senior most in UAE probably, along with Dr. Sebastian. I think, and he has been really instrumental in taking cardiology from a scratch in UAE to a really high level and arranging and initiating such kind of conferences. So, especially the CSI body. So I welcome Dr. Rajiv Lochin for your wonderful talk. You're including the electrical abnormalities of myocardial infarction also. So I hope it will summarize the hemodynamic and electrical the effects of the myocardial infarction. That will be really interesting. And thank you, Dr. Yasmin. Your lecture was excellent.
Good afternoon, ladies and gentlemen. Herewith, I'm thankful to Dr. Mittal for organizing such an excellent meeting for the ischemic heart disease patient. Today, I'm discussing saving deaths and damages from heart attack in Shakeheart 2021. I will give rough idea of what is the damage from the cardiovascular disease. On the average, more than 17 million patients die every year from ischemic heart disease. If we look at the data from the Europe, alone in Europe, 4 million people die either from the coronary artery disease or stroke. If we let's further split it, so every day 2,000 Americans die from the coronary cardiovascular disease. If we subanalyze, it's roughly one death every 40 seconds. I will try to present my experience in terms of my data of patients, case studies, which will explain my justification for the topic. There's a male patient of 50 years who presented with the acute shortness of breath via emergency room. He was severely hypoxic, requiring immediate ventilation, and for acute pulmonary edema. He also had in past high blood pressure and cholesterol, for which he was not regularly taking treatment. He had a strong family history in father and brother who died with similar episodes in past. His ECG showed left ventricular hypertrophy rather than ST elevation, with minimal ST elevation and anterior leads. Echocardiogram showed akinesia and grossly reduced ejection fraction. His BNP was markedly enlarged, raised. The acute management was done by ventilation. Thrombolysis was considered safer in view of the renal impairment, and primary angioplasty was not done. Patient remained on ventilator support, and he had shown some labile ECG changes in the follow-up after a few days. Then coronary angiogram was done, which showed disease, triple vessel disease, and recanalized left antidescending artery, possibly after thrombolysis. You can see multiple lesions here, right artery totally blocked, distal circumflex totally blocked, and diffusely diseased artery. He was managed with coronary stents in LAD. He remained stable, and after a few days, he had another episode of hypotension and left ventricular failure. His check angiogram was considered suitable, and he was taken, which showed subacute obstruction in the stent in LAD, which was managed with the balloon dilatation. And you want to just highlight that we use stent clear, which is like a stent boost program, where you use less amount of contrast and defining the anatomy or the location of the stent. So patient was discharged very nicely, but it took very long recovery time in the hospital, coming out with the cardiogenic shock, gradually weaning off the inotropes, went intra-aortic balloon pump and ventilatory support. He had a recurrent ventricular tachycardia, treated with amiodarone, and he had a residual renal failure. He had a prolonged recovery. Now he has improved gradually. After 4 months, he can walk up to 4 kilometers with the renal impairment is still present, and he's on Entresto as a part of the heart failure treatment. So in long-term plan is to complete recovery of the renal function, hopefully by conservative mechanism, and he will have a repeat angiography to define the residual anatomy of the coronary artery. Whether he can be managed by bypass surgery or interventional, both will be a challenge in this case because of the diffuse disease, and his emphasis of the lifestyle modification has been emphasized. Let's go to another case. She's a lady who drove to the hospital bank officer with shoulder pain and then some chest discomfort. ECG showed STEMI. While being recorded, he developed ventricular fibrillation requiring resuscitation and ventilation. She was transferred to PCI capable hospital where LAD, which was totally blocked, was opened up, and ejection fraction echo was 30%. So we learned that it took about 153 minutes to recanalize the artery after transfer, whether it is safe or should we have thrombolized this patient because it is beyond the expected or beyond the usual time delay which is acceptable in the various trials. So because thrombolysis can still improve the circulation, limit the ongoing ischemia, and salvage the macro, provided it is successful. It does not happen in all the cases. So these are the few things which can be discussed in this case. In follow-up, patient has been comfortable for 3 years and walks regularly, but evaluation showed echo has improved 30 to 45% ejection fraction. Stress test still shows ischemia, and angiogram revealed restenosis in both sides of the stent. Right, other arteries were normal. She required another stent, long stent placement, which was effectively done with the IVUS confirmation of the narrowing, also improvement in the dilatation or opposition of the stent. So recovery in secondary stage is important for prevention, secondary prevention, regular strict diet, and lower target for LDL. Let's see the case of left main, which has a stenosis and acute coronary syndrome. 50-year male presented with angina. Stress test was very positive after the stage 1 with ST elevation and AVR. Echocardiogram was normal. Angiogram left main 99% and multivessel disease. So it should be one of the indication is a class 1 indication for surgery, but she refused, and because of the logistics, is going to write almost subtotal cutoff of left main stem, distal left main stem, which other vessels disease as well. You can see in other views severe disease, which was taken care by initial balloon dilatation, preparation for placing the stent, and then advancing the stent from left main stem to LAD, and which showed clear-cut improvement. But there was a residual stenosis and circumflex and RCA, which was left for the second stage. And after 2 months, re-evaluation angiogram was done, which showed patent left main and LAD, and residual 2 stents were placed in RCA and circumflex easily without much discomfort to the patient and without much stress to the operator. So advantage of the stage PCI is safer than 3-vessel angioplasty in the same sitting in unstable patient, not on dual antiplated. Second stage procedure gave chance of reviewing left main stem status, better imaging and IVUS gain, maintenance in the lumen of the follow-up, and complete revascularization with a less challenging state for operator as well as for the patient. Another case which came with acute anterior MI showed proximal total block, and as per JCI protocol, in a primary PCI was performed within 52 minutes from door to balloon time in a culprit vessel only in a JCI accredited AMI center with well-established heart attack center protocol. But the patient had recurrence of dyspnea and discomfort next day, which when the angiogram showed subacute thrombus, which needs a balloon dilatation and re-angioplasty, along with opening of the left circumflex artery. Patient was stabilized and gradually discharged after prolonged recovery. So adverse prognosis in infarct-related artery has been noticed by national data, and it showed that stage revascularization over 2.5 years infarct-related angioplasty only had more MACE like death, re-MI, or re-aspilation, or re-procedure. So 4 trials were later on seen. They all have advocated multi-vessel angioplasty in a slightly different pattern in all of them. And what was shown in this trial, primary outcome was significantly reduced in complete revascularization in all 4 trials. However, total mortality was not different, and some of the trials use FFR, others use just restenosis level of 50 to 70%. So revascularization of non-infarct artery should be considered in a STEMI before hospital discharge. However, time frame has not been recommended. Similarly, a meta-analysis also recommended complete revascularization at the index procedure, either at the same time or a stage, which has get a better outcome. And the guidelines has shown routine revascularization of non-infarct-related lesion should be considered in STEMI with patient with multivessel disease before discharge. Cardiogenic shock, it is recommended that should be used. And what damages can happen in the complete revascularization during primary PCI? Large dye load can have renal impairment or left ventricular failure, destabilizing the stable coronary artery disease. It can include subacute thrombosis and reocclusion, and in case of LVF, improves the outcome. And in cases, advantages of non-infarct-related PCI, it decreases revascularization rate, reduces patients' discomfort of 2 procedures, and decreases hospitalization cost of complete revascularization and risk of 2 invasive procedures, may improve mortality. Larger experience and longer follow-up data is needed. Probably it might save life. So far, data is limited. So in conclusion, primary PCI in acute MI is preferred mode of treatment. Hemodynamically compromised patient who have high mortality if not managed early and appropriately with tailor-made treatment plan. Maximum benefit comes from earliest reperfusion, irrespective of modality in select cases. Timely intervention results in regaining near normal ejection fraction, which reduces morbidity and long-term mortality. Multi-vessel PCI in STEMI reduces morbidity. Culprit vessel only primary PCI in triple vessel disease with left main stem save lives as per our experience, and it may be applied to others. So in case saving death from damages from heart attacks, at this meeting, I would say saving lives from heart attacks. Thank you very much.
Clear message. Maybe move to the next presenter.
Yes. Please carry on. We have the next speaker ready. Dr. Rami. Dr. Rami, you have to unmute.
Tried it. Okay, fine. Fair enough.
Yes. Yes.
Really good. So Dr. Lukraz, he's the Chief Consultant Cardiothoracic Surgeon at the American Hospital in Dubai. And today he's gonna share with us the surgeon's perspective in and role in the acute MI care. Dr. Lukraz, please.
Thank you.
Good evening. I'm Dr. Heyman Lukraz. I'm a consultant cardiothoracic surgeon based at the American Hospital in Dubai. And I'm going to talk to you about the surgeon's role in acute MI care. First of all, I would like to thank the organizers of the Shakeheart annual conference, in particular Dr. Mittal, for the invitation. I have no disclosures. During this talk, I'm going to touch briefly on the guidelines, look at the potential roles of the surgeon in this the management of patients with acute MI, and go through some of the outcomes that we have when we do get involved with these patients. In terms of the guidelines, the bulk of the guideline is directed towards reducing the ischemic time, which is the right thing to do. And the surgeon as such is part of the heart team discussion, but actually is not involved a lot when it comes to hands-on management of these patients. The European guidelines have all stressed the importance of this approach to reduce the time of myocardial ischemia. Likewise, the American guidelines is based mostly on reducing the damage caused to the myocardium, and CABG for these patients takes a very small part in the management. For me, as a surgeon, when we discuss the surgical approach to the patient with an acute MI, it's like a disaster zone. There's lack of perfusion to the myocardium. There's myocardium that's being lost every minute. Sometimes they present with problems like rupture of myocardial wall, and sometimes with volume overload when you have papillary muscle rupture. Rarely we can get some uncontrolled arrhythmias, which also can make the management of these patients quite difficult. So I will touch on when the surgeons get involved, when the anatomy is not suitable for PCI or PCI has failed, and also deal with the complications that may arise following a STEMI. Emergency or salvage CABG is becoming rare, and that's mostly because of primary PCI and fibrinolytic therapies. Currently, in most databases, they will represent only about 2% of all the CABGs that are being done. In the UK, we define emergency as any surgery done within 24 hours of hospital admission, or salvage when we are actually doing cardiac massage prior to the procedure. These are certainly very high-risk procedures, and we know that especially if the CABG is performed within 3 days of the event, the risk is much higher. We as surgeons would prepare ourselves to face quite significant post-operative complications in these patients, but that's the norm in this group of patients. The silver lining to this approach is that mortality over time has improved. The surgeons have understood pathology much better, and the team looking after these patients have developed a much better quality of care. We even now have some data looking at long-term survival, which I'm going to share with you shortly. This is the data from the SCTS Blue Book. This is the UK cardiac surgery book. And if we look at mortality at the start of the century, it was about 12% in patients undergoing emergency CABG. Now it's halved to only 6%. More interestingly, the expected mortality in the early 2000s was about 18%, and now we are operating on a much higher risk group of patients with expected mortality of 26%, and yet achieving a very good survival rate. That translates to a 74% reduction in the risk of this patient, which we are now offering emergency CABG to. In terms of the postoperative care, as expected, we do see a lot of bleeding in these patients. Majority of these patients would have gone through the cath lab, have been given dual antiplatelet therapy, and many other antithrombotic agents. And re-exploration for bleeding, that is taking the patient back to the operating room after having done the surgery, is quite high in about 15% of patients. Usually in an elective CABG case, we expect re-exploration rate to be about 3 to 5%. Likewise, the mean blood transfusion is around 5 units, and that's associated with its own other problems like lung injury, external wound infection, acute kidney injury, and a slightly higher risk of the need for mechanical circulatory support and strokes. Some long-term data has recently been published from our Scandinavian friends, which shows in red the survival of the emergency CABG, and in blue, survival of the salvage CABG. As we can see, the first initial drop-off levels off thereafter, giving a 5-year survival for the emergency group of around 80%, which is very good. And even in the salvage group, where we're massaging the chest prior to getting to the OR, we still achieve a survival of around 50% at 5 years. In terms of post-infarct VSD, luckily it is getting less. Incidence is reported around 0.2%, usually presents within the first 24 hours of the event, but up to 7 days is possible. These patients are in cardiogenic shock. Mortality is usually quite high, and the treatment options are either medical therapy, surgical repair, and transcatheter closure. With both of these latter approaches, they may end up with a residual shunt, but of a smaller size in nature. The timing of the treatment is very important, and overall, it's felt that repairs performed after 2 weeks of the event ends up with a better outcome. And this has been proven by this publication, which reviewed the literature for over a period of nearly 40 years, some 650 patients. And what we can see is mortality for medical therapy alone is quite high, as I mentioned already, over 90%. Whether it is surgery or whether it is transcatheter closures, late approach has a lower mortality, and transcatheter closure, if available and feasible for the size of the VSD, then they are also associated with a much better survival if performed after 2 weeks. Ventricular free wall rupture, fortunately, is fatal in most patients. Most of the diagnoses are made in autopsy studies, and when the patient has a ventricular free wall rupture, you end up with cardiac arrest, hypovolemia, and electromechanical dissociation. But very few patients who do make it through the cardiac arrest resuscitation and to the OR, surgical repair certainly is feasible, along with revascularization as deemed appropriate in that group. Papillary muscle rupture is reported to be in around 0.03% of patients presenting with a STEMI. Most commonly, it's a posteromedial papillary muscle which ruptures because it has a single blood supply as compared to the anterolateral muscle, which has a dual blood supply. Usually presents within the first 13 hours of the event. Most of these patients will need some form of mechanical support, whether it is cardiovascular or ventilatory, prior to getting into the operating room. And the treatment will be with revascularization and mitral valve surgery, which can be either surgical repair or replacement of the mitral valve. Like the emergency CABGs, they are associated with significant morbidities and mortalities. from our Japanese group of friends who reported from the database in patients who had ischemic papillary rupture, the operative mortality was reported to be 25%. They do have a long postoperative stay and several complications as expected with this pathology. Life-threatening ventricular arrhythmias are known to happen after a STEMI. Luckily, very few patients need surgery for this problem, and the literature is rather sparse regarding data in terms of long-term survival. Finally, cardiogenic shock. There has been a lot being said about what type of circulatory support will be best for patients who are in cardiogenic shock. The IABP, through the IABP Shock 2 trial, has not been shown to be beneficial. Likewise, the tandem heart, which is a percutaneous ventricular assist device, and the impeller, which is an actual flow pump device, have not been demonstrated to be providing any survival benefit. However, the ECMO setup with the ventricular, the veno arterial setup has been shown to give some benefit and may be the way forward for these patients. Revascularization obviously is important to improve myocardial performance. Any type of support is associated with complication, and the more invasive the support, the more the number of possible complications, whether it is device-specific complications or other complications as a result of the device. So, in summary, the need for surgical intervention is rare, but the surgeon is always available for the heart team discussion and support as required. We as surgeons, we know that the surgical risk when we're treating these STEMI patients are high, but they are not prohibitively high. We prepare ourselves and we brace ourselves for the postoperative complications that we know will happen in this group of patients. And we get the best results when we all work as a team with the cardiologist, cardiac surgeon, cardiac anesthesiologist, our clinical perfusionist, the intensivist, and our paramedical team with the nurses and physiotherapists and the cardiac rehabilitation team. Thank you very much for your attention. I'll be delighted to take any questions at the end of this session. Thank you.
Well, thank you for a very comprehensive and elegant talk, Dr. Lucas. Anyone would like to have any discussion regarding any of the topics?
Yeah, first I will just welcome Dr. Rajiv Gupta, who for some technical glitches he could not join earlier. So we still give you enough honor to be an honorable moderator in this session. So you are part of the moderation. Now we have officially 5 minutes, but we can extend another couple of minutes if need be. So please, by next 7-8 minutes, we can complete. 9:02, 9:03 is the last final. We'll complete. So now the moderators, all three moderators and the speakers will take care of the rest of the session. Thank you.
Dr. Yasmin, if you don't mind, what do you think about adding the FFR CT or a CT perfusion to the anatomical study that is CTA? Would you consider this would be a better option than doing only a CTA alone or a perfusion study like a SPECT or a stress MRI?
Well, actually, yes, the invasive FFR has been tested, not the non-invasive FFR by cardiac CT in the trial, and maybe because it's just an emerging technology right now, not because it's inferior to the invasive FFR. But the evidence goes also with the invasive FFR when it's significant
this has been taken into account to go on with the revascularization. But as I mentioned in the guidelines, that it was only class 2B, according to the level of the ischemia or the invasive FFR, it's only class 2B. So it was not really clear direct indication. But with ischemia trial, this has been taken into account. FFR, if it's significant, then you go ahead with the revascularization. But what's interesting in ischemia trial is that regardless of the amount of the ischemia, the outcome is not significant. This is what is really new to the literature, that we thought that if it's severe ischemia, but the patient is stable and the ejection fraction is stable and he's asymptomatic, then you don't have to intervene and you go ahead with revascularization as previously has been thought. And FFR, as I said, is being tested, but non-invasive FFR not been tested yet.
I have a question for Dr. Heyman. Thank you, Dr. Heyman, for this analysis of the surgical aspect, surgical perspective. I wanted to know how often you have done VSD closures in cases of rupture. And as we heard with the previous speaker, he's talked about putting a patch in the surrounding normal myocardium, leaving the scar tissue, quite a good area ahead of the scar tissue, so that we don't end up in a patch, this a poor coaptation, or what you call as possible removal of the patch.
Yeah, I think, I mean, luckily with primary PCI, we see very, very few of these VSDs these days. Obviously, where there is thrombolytic therapy still being practiced, and where there is not even thrombolytic therapy and the patient ends up with an MI, in those areas, you will still see these VSD patients. The last time I closed an ischemic VSD was nearly 10 years ago now. And the difficulty with these patients is that when they present, they are very sick. And as a physician, as a doctor, and as a surgeon, certainly, you want to do something very quickly. And you actually see them deteriorate quite rapidly over a period of hours. And you feel this impulsion of going in and sorting it all out. Over the years, my experience with this has been that in the early days, when we used to take them in early, within the first few days of the event, it invariably ended up in a disaster. And that was mostly because of the reason you've just mentioned, is you have so much of mushy myocardium, and it's so difficult to delineate where good myocardium is and where myocardium is unlikely to survive is in an early stage. And you put your sutures in an area where you think, oh, that looks good, and you take your bite. Because you do the surgery on an arrested heart, it looks like everything is looking very good. And you close everything up, you come off bypass, and you do a TOE, and the patch just is good for maybe 10 beats, and after the 11th beat, the VSD reappears. And it's so demoralizing at that point that you've spent 5 hours repairing something and it's just not going to work. And I think that the study, especially the data which I presented, where it showed that delaying is better, actually does help, because it allows some of this myocardium to start to fibrose, and it allows you then to delineate where good and bad myocardium is. The unfortunate the morality of this practice is that while waiting, you will have some patients who will not make it. But these patients, even with surgery, wouldn't have made it anyway. So it's a difficult decision. But I think this issue about patch coming off is very common if you try and patch it early. It's less common when you go and patch it much later on in your, during the event.
But if the patient is hemodynamically stable, do you consider such patients? I know the frequency has gone very low. That's a good news. But can we take them on pump instead of on pump, off pump, to have a better delineation, and it would appear the appearance of the myocardium delineation would be better?
No, the delineation of the myocardium doesn't depend whether it's done on pump or off pump. It just depends on how long it's taken for natural pathological processes to undergo their process. And that's a process of necrosis and fibrosis.
So it's the
So you
time
need to give
relevance.
time.
Okay.
It is, that's right. You need to give time. And you can't do it off pump, this procedure, because you are dealing with both the right and the left side of the heart. And you can't open the left side of the heart to air because you need to open the heart to patch it. And if you open the left side to the heart to air, then air will get into the circulatory system and you'll end up with a massive, embolism, whether to the brain or to any part of the body. Yeah.
Thank you. I have one question for Dr. Lochin, if time allows me.
I think we still have 1 or 2 minutes.
So, Dr. Lochin, you talked about the multivessel disease and complete revascularization. We have also heard about this complete trial where they've shown that definitely a complete revascularization reduces the MACE. And so what do you do in real practice? Do you do an FFR for the non-culprit, non-IRA related vessel and then take the decision of doing it, because time is also important in such patients? So it's just the visual estimation of the stenosis? We can't hear you, Dr. Lochin.
Forgot to unmute myself. Sorry about that.
Sorry.
So what I'm saying that it has to be tailor-made decision. It cannot be one general rule will not apply to everyone. And as probably if you have seen in my presentation, they had the left main distally almost totally disconnected, and he had LAD circumflex RCA disease, and patient totally refused to go for surgery because we were very scared to take this procedure. You have a distal left main 99% blocked. And then we eventually did a LAD to left main to LAD angioplasty and mid LAD angioplasty in the same sitting, and left the patient's RCA and circumflex for the next sitting. And I did it after 2 months, and the whole idea was that it will give us me time. If there is a reocclusion of LAD or left main, we will refix it or send it to surgery. That was the whole plan. Luckily, it remained open 2 months' time. It gave us a confidence, and it was very easy to do in second sitting 2 other stents. At this time, patient was absolutely stable. So it was, in this case, it was not required. In others, where is a doubtful lesion, we do a FFR. If it is 50-60% lesion and you have to do something, then FFR is a better decision at that time, and then take the decision accordingly. So this is the protocol which we are following. And we have done many multi-vessel and some patients with left mid disease as well. Thank you.
Thank you. Thank you, Dr. Lochin.
So let's finish it off. Now we are already over the board. So I'll request you to wind up. It was an interesting discussion.
Thank you for an interesting session.
Thank you very much.
Thank you for the invitation. Thank you.
Thank you, all the moderators, all the speakers for taking out time. And I'm sorry I have to wind it up because of the other logistic issues. Team is all waiting to wind up. So thank you so much. See you all tomorrow, 3 p.m. Tomorrow we start at 3 p.m. There is a symposium between 3 and 4 in association with Saudi Heart Association. So, and then the program continues until 9 p.m. So thank you so very much. Wonderful. Have a good night. And Dr. Gupta, Rajiv Gupta, please join us again tomorrow. And we missed your comments, but maybe tomorrow we'll have more.
Thank you, Dr.
Good
Thank
night.
you. Good night.
Thank you. Good night. Good night. Thank you so much. Thank you. Thank you. Thank you.